السلام عليكم.
وعليكم السلام ورحمة الله.
وعليكم السلام ورحمة الله.
Assalamu alaikum wa rahmatullah. Welcome everyone in our third and last day of our diabetes education and management webinar. The first topic that we'll be discussing today is the potential complications of diabetes in terms of the intermediate complications. For children with type 1 diabetes, their growth and development can be impaired with diabetes, as adequate protein and energy must be provided to promote their growth and normal development with catch-up growth. So children can be big eaters in terms of choosing the food they would like the most, but we should, as much as possible, implement healthy like food choices in order to improve their general well-being and maintain somewhat of a normal glycemia. Also, in children with type 1 diabetes, their blood glucose goals are less strict than that of adults. As we have mentioned, they can be sometimes picky eater, but we also need to promote their growth and catch up growth. So we can have some flexibility in their blood glucose levels. The target range for a normal blood glucose level is between 90 to 130 milligram per deciliter. This is before eating in 13 to 19 years old children. The value is somewhat more in children who are younger, between the ages of 16 to 12, and even somewhat higher in children between 0 to 5 years of age. So these may be altered according to the healthcare provider evaluation, therefore individualized care plan for each patient. So a near normalization of the blood glucose level is the most important or attainable in children and also adolescents after the honeymoon remission period. So their A1C level goals also varies, and most children under the age of 6 or even 7 have a hypoglycemic unawareness. So because this is due to the fact that they lack the cognitive capacity to recognize and respond to hypoglycemic symptoms. So children with diabetes can differ from adults in many ways, including the insulin sensitivity related to the sexual maturity, their physical growth, ability to provide self-care, their vulnerability to hypoglycemia, and the differing family dynamics and socioeconomic status with their developmental stage and also physiological differences. We should also work with the family and school to plan for emergencies, such as the occurrence of a low or high blood glucose levels. And for children with type 2 diabetes, the distinction between type 1 and type 2 in children can be sometimes difficult to interpret. This is due to the autoantigens and ketones that can be present in a substantial number of patients. And children with type 2 are usually overweight or even obese and can present with glycosuria and even with or without ketonuria. In addition, there is absent or even mild polyuria and polydipsia with little or even no weight loss at all. And up to 33% of children have ketonuria at diagnosis, while some can have ketoacidosis without any associated stress, illness, or even infections. In preconception, all women who have diabetes and who are of a childbearing potential should be educated about the need for good glucose control before they become pregnant. There is also a need for family planning and the need for an early treatment for diabetic retinopathy, nephropathy, neuropathy, and also cardiovascular diseases. And for A1C levels, it should be normal or as close to normal as possible, as even a slightly 1% above the upper limit of the normal in an individual before consumption is attempted can be helpful in improving the general outcome of the pregnancy. And for pregnancy and diabetes, as infant mortality rates are approximately twice as high for babies who are born to women with uncontrollable diabetes compared with babies who are born to women who doesn't have diabetes. So to reduce the risk of fetal malformations and maternal or even fetal complication, Any pregnant women and women who are planning to become pregnant requires excellent blood glucose control. And these women need to be seen frequently by a multidisciplinary team to assess their overall health and to plan for a better pregnancy. Also, a specialized laboratory and diagnostic test may be needed in some of the cases, and also females with diabetes must be trained in the self-monitoring of blood glucose levels. In addition, nutrition recommendation for women who have a pre-existing diabetes must be based on a thorough assessment for their overall health status. We should also have monitoring of blood glucose level in the blood or even urine ketones with the patient appetite and weight loss gain that is needed to develop an individualized nutrition prescription and also to make adjustment to the meal plan. In addition, the plasma glucose should be maintained at 65 to 100 milligram per deciliter. This is before meals, and in fasting, it should be between 110 to 135. This should be between after 1 hour after meals, and a result or a value between 120 milligram. This is the normal value for 2 hours after meals. In addition, using an extra 300 kilocalorie on a daily basis during the second and also the third trimester is required with the addition of 25 approximately grams per day of protein and no less than 175 grams per day of carbohydrate and 1600 grams of folic acid. Also, adding iron and calcium can be required depending on the patient's status. And in lactation, the female patients who have diabetes will require extra protein, calcium, and folic acid. In addition, the monitoring of blood glucose is recommended, but also hypoglycemia should be avoided as much as possible. And in breastfeeding, it can lower the blood glucose levels, and women can require eating extra carbohydrate containing snacks either before or even during breastfeeding. And the addition of 300 to even 400 kilocalorie per day can meet this need of an increased metabolic status of most lactating mothers. And in older adults, there is unexplained weight loss that should be viewed as a symptom of a problem or a symptom of developing diabetes. And diabetes is considered an important health condition for the aging population, as at least 20% of patients who are over 65 will develop or have diabetes. So these patients tend to have a higher rate of premature death and functional disability with coexisting illnesses such as hypertension, heart disease, and even stroke than those without having diabetes. Also, in the new onset diabetes in adults who are over the age 50, this can signal an underlying pancreatic cancer, which should be investigated thoroughly. Also, a strict diet in a long-term care are not warranted and can lead to dehydration and malnutrition. Therefore, a specialized diabetic diet are not required in older patients, but should be replaced with a balanced diet that has a consistent timing of carbohydrate intake, which is always recommended. In older patients, we should modify their medication rather than the diet itself as needed, depending on the case. We should also have a lower hypertension results or values gradually by implementing the DASH diet whenever it is feasible or possible. Also, a multivitamin mineral supplement can be beneficial for this population. After discussing the intermediate complications of diabetes, now we will start with discussing the potential chronic complication for diabetes. So retinopathy is considered one of the most common side effects or chronic complications of diabetes. It can account as up to 12,000% or even 24,000 cases of blindness each year that is due to diabetes. And optimal glycemic and blood pressure control can substantially reduce the risk and the progression of diabetic retinopathy. And in the presence of a proliferative diabetic retinopathy or a severe non-proliferative diabetic retinopathy, a vigorous aerobic or even resistance exercise can be contraindicated due to the risk of triggering a vitreous hemorrhage or even retinal detachment. And pregnancy in type 1 diabetes can aggravate the occurrence of retinopathy, while a laser photocoagulation surgery can minimize this risk. Another potential and chronic complication of diabetes is microalbuminuria and nephropathy. So early signs of nephropathy can include hyperfiltration, renal hypertrophy, and also microalbuminuria, which is the loss of about 30 to up to 300 grams per milligram of creatinine in urine. So the protein losses at a rate of about 300 grams per milligram of creatinine can indicate an advancement toward a chronic kidney disease. And to reduce this risk or even to slow the progression of nephropathy, we should optimize the glucose and the blood pressure control. As nephropathy in most cases is preceded by microalbuminuria for several years, then the onset of an end-stage renal disease is about 5 years after the onset of microalbuminuria. And for patients who are diabetic and have nephropathy, a liberalized carbohydrate intake and also controlling the insulin level accordingly depending on the patient's values. Also controlling the protein intake will slow down the progression of the nephropathy. And a maximum or optimum requirement for protein is about 0.8 to 1 gram per kg on a daily basis. And the protein restriction is of benefit in slowing the progression of albuminuria, the glomerular filtration rate declines, and also the occurrence of an end-stage renal disease. For the protein restriction, it should be considered only in patients whose nephropathy seem to be progressing despite any optimal glucose and blood pressure control. And also if they are using angiotensin converting enzyme inhibitors or ARBs. So an intensive diabetes management with the goal of achieving a near normal glycemia has been shown to delay the onset of microalbuminuria. Therefore, we should refer to a physician who is experienced in the care of diabetic renal disease when the estimated GFR is below 60 milli per minute, or if there are difficulties that occur in the management of hypertension or in hyperkalemia. For ACE inhibitors, they are almost always prescribed to decrease the progression of the renal disease. In the case of the occurrence of an end-stage renal disease, as diabetes is considered the leading cause of chronic kidney disease, especially among patients who are Black or Mexican Americans or those who are Native American. So the diabetic nephropathy can occur in up to 40% of patients who have diabetes and is considered the single leading cause of end-stage renal disease. So a proper management for blood glucose levels from the start or from the first diagnosis is always indicated to avoid the development of such severe chronic complications. For creatinine and the GFR level, they should be assessed annually in the population who are considered at risk, and especially in any diabetic patient who doesn't have an appropriate blood glucose level control. The microalbuminuria, which is a level between 30 to up to 300 milligram in 24 hours, and also a macroalbuminuria, which is defined as 300 milligram per 24 hours, should be carefully monitored in all patients. And while the physical activity can actually increase the urinary protein excretion, there is no evidence that any vigorous exercise can increase the rate of progression of a diabetic kidney disease. So this is doesn't have any complication or implication as it is believed to be. In the case of an autonomic neuropathy, about 70% of people who have diabetes will have some degree of a neuropathy, including an impaired sensation in the hand and the feet with slowed down digestion or even carpal tunnel syndrome. كان في أحد استفسر مني بخصوص هذه النقطة في أول يوم إذا بيأثر الدايابيتس على الأعصاب في اليد. هنا الشرح المفصل إحنا جاوبنا على السؤال لكن هنا الشرح المفصل أيضا موجود. So it is true that diabetes neuropathy affect about 70% of persons who have diabetes. So an autonomic neuropathy can decrease the cardiac responsiveness to exercise, causing a postural hypotension, an impaired thermoregulation, and an impaired skin blood flow with sweating, with impaired night vision, and thirst with the risk of developing dehydration, and also gastroparesis with an unpredictable food delivery. Also, neuropathy can be delayed with careful blood glucose management. In addition, weight loss can be beneficial for obese persons to help better in avoiding these complications and having a better glucose control. For the skin and joints, there is also decreased pain sensation in the extremity that can increase the risk of a skin breakdown and also infection with joint destruction. This can be best to encourage the non-weight-bearing activities such as swimming, bicycling, or arm exercise to help better improve the general health and avoid the development of these complications. Also, diabetic autonomic neuropathy is associated with recurrent geniotomy of the tract, disturbance, or even bladder or even sexual dysfunction. In regard to amputation, which is one of the more severe or associated signs or symptoms with diabetes, a lower extremity amputation are painful and also disabling, so the prevention is very desired for improving the patient's quality of life in general. And amputation of the with foot ulcer are the most common consequences of diabetic neuropathy and also the major causes of morbidity and disability in people who have diabetes. In terms of cardiac neuropathy, a major clinical manifestation of cardiac neuropathy in diabetes can include resting tachycardia, exercise intolerance, orthostatic hypotension, constipation with gastroparesis, erectile dysfunction, pseudomotor dysfunction, and also impaired neurovascular function and hypoglycemic autonomic failure. Therefore, we should evaluate the cardiac status before starting any exercise program for any diabetic patient. For gastrointestinal neuropathy, as GI disturbance including esophageal enteropathy, gastroparesis, constipation, or even diarrhea with fecal inconsistencies are all considered common chronic side effects of diabetes, which can affect any section of the GI tract depending on the patient condition. Also, gastroparesis should be suspected in any individuals who have erratic glucose control. In macrovascular coronary artery disease and also arterial vascular diseases, as CVD is a major cause of mortality and also a major contributor to morbidity in diabetes, it should be managed closely or monitored closely to prevent the development of such complications. So type 2 diabetes is an independent risk factor for macrovascular diseases. And therefore, any patient who have type 2 diabetes should be monitored closely. And other risk factors can include insulin resistance, hyperglycemia, hypertension, dyslipidemia, and smoking. Also, smoking is related to the premature development of microvascular complication of diabetes and can also have a role in the development of type 2 diabetes. And we should advise all patients not to smoke, including smoking cessation as a routine of component of the care. Another chronic complication of diabetes is dyslipidemia, as lifestyle modification can focus on the reduction of the saturated fat and also cholesterol intake with weight loss if it was indicated, and increasing the physical activity. All of these simple intervention has showed an improvement in the lipid profile of patients who have diabetes. Therefore, this has resulted in a general improvement on their health conditions. So the guidelines promote a low density lipoprotein cholesterol level of a 100 milligram as an optimal guidelines or value for all patients, with lowering the triglyceride level when it is 150 milligram. In addition, statin can be helpful as a treatment option with the elevation of HDL level to about 50 milligram. And if the HDL is 50 milligram and the LDL is between 100 and 130, then a fibric acid derivatase or a niacin can be used as a treatment option. Also, niacin can raise HDL level and can significantly increase the blood glucose at a high dose. Using aspirin therapy as a secondary prevention strategies in those who have diabetes and a history of CVD is recommended. In addition, we should tailor the nutritional interventions according to each patient age, type of diabetes, their pharmacological treatment, and the lipid profile or any other medical condition, depending on the patient's general health. We should also focus on the reduction of saturated fat, cholesterol, and trans fat intake, and we should monitor the homocysteine levels and the related action according to the patient's values. Also, adequate insulin therapy often returns the lipid levels to the normal in patients who have type 1 diabetes, while an elevated levels in type 2 diabetes can require more strict management by limiting the saturated fat to up to 10% of the total caloric intake. According to the rate of heart disease, it is about 2 to even 4 times higher in adults who have diabetes. So it is considered the leading cause of diabetes-related deaths. And since people with diabetes tend to have a high triglyceride and a low HDL levels, so omega-3 fatty acid supplementation from DHA and EPA can be helpful as an auxiliary management technique. Another common complication for diabetes is hypertension, as over 70% of adults who have diabetes also develop hypertension. And controlling hypertension in diabetic patients was linked to a reduction in the progression of both the microvascular and also the macrovascular disease. And in type 1 diabetes, hypertension is often the result of an underlying nephropathy, where in type 2 diabetes, it can be present as a part of the metabolic syndrome. And in patients who have systolic blood pressure of 140 or a diastolic blood pressure of 90, then they should receive a drug therapy in addition to lifestyle and behavioral therapy. So the blood pressure should be measured at every routine diabetic clinic visit, and patients who have diabetes should be treated to reach a systolic blood pressure of 130, while their diastolic blood pressure should be 80. And in patients who have type 1 diabetes, with also hypertension and any other degree of the presence of albuminuria, then ACE inhibitors have been shown to delay or prevent the progression of nephropathy. While with type 2 diabetes, hypertension, and microalbuminuria, using ACE inhibitors and also ARBs has been shown to delay the progression of the development of macroalbuminuria. In addition, a modest weight loss is always helpful in a patient who is overweight, and we should prevent the development of hypokalemia, which can blunt the insulin release. We should also control the glucose by limiting smoking and adding exercise, depending, of course, on the patient tolerance, and using DASH diet because it can increase the intake of calcium, magnesium, and potassium, while lowering the excessive weight is always also recommended. Also, hypertension in diabetic and pregnant women is a serious or chronic complication that we should be careful or monitor for. So a pregnancy-induced hypertension is 2 to even 4 times more common in women who have type 1 diabetes than in the general population. Therefore, screening for the presence of microalbuminuria as a strong predictor for preeclampsia is indicated. Also, in the presence of in the pregnant patient who have diabetes and chronic hypertension, then their blood pressure target goals should be between 110 to 130 over 65 up to 80. And they should avoid a lower pressure values because the fetal growth can be impaired and negatively affected. Also, ACE inhibitors with ARBs are contraindicated during pregnancy, and they should monitor therefore carefully and have specified management plans for pregnant women. Also, stroke is considered as a risk factor in even 2 or even 4 times of risk factor for the development among patients who have diabetes. Also, high blood pressure should be carefully controlled to prevent the risk of developing stroke or cardiovascular diseases. In addition, catabolic illnesses such as HIV infection, AIDS, or even cancer can be as a risk factor for diabetic patients who have poor blood glucose control, as it changes in the body compartment with increasing extracellular fluid and also shrink of age of the body fat and cell mass can all be risk factors. Therefore, we should monitor the patient for any unexplained weight loss carefully, especially if they have 10% or more of the usual body weight as a fat loss, and this was an unplanned weight loss occurs. In the cases of catabolic illnesses, a standard tube feeding are usually well tolerated in patients who have diabetes, with a content of about 50% from carbohydrate or even lower. But we should, in this case, monitor the fluid status, the weight, and the plasma glucose with the electrolyte levels and the acid-base balance. As overfeeding is to be avoided, and we should start with a simple feeding between 25 up to 35 kilocalorie per kg of the body weight. The protein needs in catabolic illnesses can be up to 1 gram per kg or even higher as 1.5 gram per kg in any stressed individuals, and also in those having pressure ulcer, as they can require higher level of protein and calories than the normal for promoting healing. Also, the addition of insulin can be needed, and oral glucose-lowering medication need to be adjusted to achieve an adequate control of glycemia. Another common chronic complication for diabetes is diabetic gastroparesis. So gastroparesis can occur in approximately 50% of all cases of diabetic patients with delayed gastric emptying in the absence of a mechanical obstruction. And diabetic gastroparesis is the result of an ongoing damage to the nerves that are responsible for peristalsis and the normal motility. So the food digests abnormally slowly, or even peristalsis is diminished so that it is difficult to match the insulin action to the digestion and also absorption of the meals. And if food can stay in the stomach too long, then infection is possible as a side effect. And if the food can harden into a solid lump, then this will be bizarre and causes pain, nausea, and even can block the digestive tract. In addition, hypoglycemia can occur if the insulin is working and if the food remains in the stomach for too long. And later on, the insulin action is completely diminished and the food will finally digest, causing the occurrence of hyperglycemia. So problems occur more often in type 1 than in type 2 diabetes for those having gastroparesis. So a strict glycemic control is the key for preventing gastroparesis. Also, a gastrostomy is rarely indicated in those patients, but a jejunostomy can be helpful in maintaining their nutritional status. A prokinetic agent are considered the best treatment option, and a gastric electrical stimulation can be used to send out a brief and low energy impulses to the stomach and to decrease the nausea and the vomiting accordingly. So the gastric electrical stimulation can be used as a method, as we said, to decrease nausea and vomiting. For the intervention, we should aim to correct the fluctuating blood glucose level through careful food and insulin management with frequent blood glucose check and also monitoring the records. And in the case of the presence for nausea and vomiting, we should restore the volume and the hydration and also provide antiemetic agents generously. We should also aim to relieve the symptoms such as pain, diarrhea, and constipation with maintaining adequate nutritional status. And differentiation from ketoacidosis, which has similar symptoms to nausea and vomiting, is a key indicator in patients who have diabetes. And we should prevent the infection or the bizarre formation from accumulation in the indigestible solids, such as the case of gastroparesis. For nutritional management, we should monitor the patient oral intake carefully, and this will help in better controlling the glucose level and preventing their fluctuating values. Moreover, we should include about 200 up to 240 grams of carbohydrate on a daily basis, and also this should be spread out through the day to prevent the occurrence of hyperglycemia after a particular meal. So we should use about 2 to even 3 carbohydrate serving in each meal. We should also advise the patient to be consistent from day to day and have a consistent content of carbohydrate in each meal and also a consistent time of consuming their meals. And the soft to even liquid diet can be useful to prevent or even delay to prevent the delay in gastric emptying in general. So a recommended 6 small feeding or meals can be better tolerated than the larger meal, and using a low-fat diet can help in improving digestion and also to improve the stomach emptying in general. Also, advising the patient to stay in an upright position or sitting position while eating is always recommended. And decreasing the overall fiber intake from meals or supplements is also recommended. And having orange, broccoli, or green beans can all be difficult to digest. Therefore, these should be avoided or reducing their intake. And in the case of the presence of a dry mouth, then adding extra fluid and moistening the food itself with broth or even allowing sauces or gravies is recommended. And if nausea occurs, then cold food or low odor food choices can be better tolerated than the hot food. And in case of severe problems, a percutaneous jejunostomy tube feeding can be indicated to avoid the occurrence of infections in the case of gastroparesis. So this tube can be used temporarily if needed to correct the malnutrition or can be used indefinitely. Some of the medication used in gastroparesis are the prokinetic, such as metoclopramide, that can be given up to 30 minutes before the meals, which can help in increasing the gastric contraction and also to relax the pyloric sphincter. And dry mouth or even sleepiness, diarrhea, or nausea can all be side effects of using this medication. Also, using imotazole, which is a nasal spray from this type of medication, can have the same side effects. And for metoclopramide prophylaxis, it can be used to reduce the gastric volumes before the elective surgery, which is unnecessary unless the patient has a prolonged history of poor blood glucose control, then they should use this medication. Also, a rapid-acting insulin should be injected with or even after meals to prevent the occurrence of hyperglycemia. And using SMPG to monitor the delayed absorption and glucose changes is also recommended. In addition, using the Lispro is quite effective because it can start working shortly after the injection. And to control the blood glucose, it may be necessary to take insulin more often than usual and to take insulin, especially after eating instead before, and also to check the blood glucose often after eating. And if the patient has a liquid diet, then more insulin can be needed, with also insulin pumps that can be beneficial because it can enhance the insulin delivery rates, which can be programmed to the patient's individual needs in specific. And because there is a reciprocal relationship between the gastric emptying and also the infant glucose concentration, then a newer diabetes therapies that can decelerate the rate of gastric emptying can be a beneficial tool for better management in these patients. So antiemetic can also be used for the presence of vomiting, and we should monitor the patient for any specific side effects. Also, Zofran can cause constipation or headache. Therefore, when given to the patient, we should ask them about these side effects in specific. Erythromycin can also improve the stomach emptying by increasing the contraction that can move the food through the stomach. But its side effects include nausea, vomiting, diarrhea, and also abdominal cramps. Also, Dramamine is an antihistamine that can help in preventing nausea and vomiting, which has a slight to moderate risk of having a side effect as drowsiness and also thickening of the bronchial secretion that can occur. In addition, Motilium, which is used to manage the upper GI problem, has side effects that can include headache. In regard to using herbs, they shouldn't be used without discussing with the physician, as we have discussed on our first day that some herbs would have a negative impact on the patient's health and also on their insulin action and their blood glucose levels. For the nutritional management, we should discuss the delayed digestion and absorption of food so that it can be managed accordingly. Also, we should discuss the role of diet in maintaining the weight and also controlling any discomfort that can be present. We should also emphasize the nutrient-dense food if the intake has been poor for a long period. with the addition that blenderized food or smoothies can be well tolerated as an option to improve the appetite. Also, the bizarre formation can occur after eating orange, coconut, or green beans. Therefore, other high fiber food also should be reduced. And we should discuss insulin management as appropriate and include information about SMPG and also the meal spacing. And we should advise the doctor if the blood glucose level are 200 milligram or more so that they can have adjustment in their insulin unit requirements. For educating the patient in regards especially to foodborne illnesses, if the patient was using tube feeding, then we should teach them on appropriate sanitation and also food handling procedures. Another common complication in diabetes is ketoacidosis. As ketones in the urine mean that the body is burning fat to get energy as a source because the glucose is not available or to be used immediately. So this lack of insulin can lead to gluconeogenesis in the liver. Therefore, the glucose will spill into the urine and causes an osmotic diuresis with the occurrence of dehydration. So the free fatty acids are then released from the adipose tissue and converted afterward into acidotic ketones by the liver as a source for energy in the body. Also, large amount of ketones in the serum and the urine can be dangerous for the patient's health. As the diabetic ketoacidosis is a classic metabolic acidosis, a medical emergency condition that accounts for more than 100,000 of hospital admission yearly for diabetic patients. And the patient who have a low serum potassium level should be assumed to have a potentially life-threatening crisis. The possible causes for DKA includes not getting enough insulin from a missed injection, or even alkaline reserve that is depleted by having too much insulin. In addition, the presence of a cold or a flu, meaning a stress state with even fever, or pregnancy can all be symptomatic causes for ketoacidosis. Also, trauma and myocardial infarction or even infections, which is considered the leading cause of DKA, including UTI infection and pneumonia, can all be possible causes for DKA. So the triad of an uncontrolled hyperglycemia, metabolic acidosis, and also an increased total body ketone concentration are all characteristic factors for DKA. So these metabolic derangements can result from the combination of an absolute or a relative insulin deficiency with increased levels of the counter-regulatory hormones of glucagon, or the catecholamines, the cortisol, and other growth hormones. So DKA is primarily seen in patients who have type 1 diabetes, and a few of patients who are diabetic with type 1 present with DKA as the initial diagnostic symptom. While in children, DKA is considered the leading cause of hospitalization and is a cause of cerebral edema, which can lead to death if it wasn't treated. Also, DKA can occur in patients who have type 2 diabetes, and this is usually from a UTI infection or trauma stress, or even in the cases of pregnancy or going through surgery, or having a myocardial infarction. So the inflammatory process can play a role in the development of DKA, and both DKA and its treatment can produce a varying degrees of immunological stress. And all individuals with DKA should be tested for the presence of hyperthyroidism. Also, we should use a standardized rating guidelines that have a merit impact on the patient's health in general. In terms of the intervention, we should aim to correct the high blood glucose level by giving the patient more insulin units and having frequent blood glucose and ketone monitoring, which is a key indicator in these cases. Also, we should note that the urine ketones can lag behind the serum ketone because it can take time to empty the bladder where they have accumulated and been stored. Therefore, it can be taking time to be detected. So replacing the fluid and electrolyte that are lost through excessive urination and vomiting is also indicated in these cases. We should also aim to promote return to wellness after a poor health condition that has occurred for several days. In addition, we should evaluate the precipitating factors such as surgery, trauma, UTI, pneumonia, or influenza to know what is the exact cause of developing DKA. We should also monitor frequently to prevent the reoccurrence of DKA and having a thorough patient education in terms of using their injections and timing of the meal. We should also prevent complications by such as shock, arterial thrombosis, or renal failure by having a normoglycemic control. Also, cerebral edema can remain a significant problem with a high mortality rate in patients who have diabetes. So, young children are especially vulnerable to CDK and can slip into the occurrence of coma if this wasn't managed immediately as an emergency case. And for a chronically high fasting glucose level, we should adjust the evening, intermediate, or the long-acting insulin doses, or even the timing of the dose, depending on the patient values. So we will be taking a break now, and then we will continue with the diagnostic criteria for DKA and the hyperosmolar hyperglycemic state. Assalamu alaikum wa rahmatullah. Welcome back, everyone. Now we will be discussing the diagnostic criteria for diabetic ketoacidosis and hyperosmolar hyperglycemic state. So the criteria include assessing one of the following: the plasma glucose, the arterial pH, the serum bicarbonate, the urine ketones, also the serum ketones with the effective serum osmolality, and assessing the patient's mental status. For the plasma glucose level, in the mild cases, it is, and also in the moderate or the severe cases, it is all more than 250 as an indicator for diabetic ketoacidosis. While in the HHS, it is more than 600. Also, the presence of an arterial pH between 7.25 to 730 is indicated of a mild DKA, while lower values can indicate a severe DKA. Also, the urine ketones and the serum ketones are positive in all of the cases of DKA, and in the HHS, there will be a small amount of urine and serum ketones present. Also, the serum osmolality is variable in DKA, but it is more than 320 in HHS. And for the mental status, the patient in the mild cases is usually alert, but in moderate cases, they can be a bit drowsy. And in severe cases of DKA and in HHS, the patient can have a stupor coma, a stupor presence, or a coma. For the nutritional intervention, if the patient is in a comatose state, then intravenous insulin, electrolyte, and fluid are used. And a nasogastric tube can be placed to prevent aspiration during the feeding, while if the patient is alert and oriented, we should offer them plenty of fluids orally. And as treatment progresses, then a 5% glucose solution is usually given as gluconuria and also in the hyperglycemic subside cases. Also, if the glucosuria and the hyperglycemia doesn't decrease, then we should try giving the patient tea and a salty broth. And afterward, we should try by giving the patient fruit juices and also liquids that are high in potassium as an option to correct the condition. So the resolution of DKA can lead to the ability to tolerate oral nutrition and also fluid, and to normalize the blood acidity of about pH 7 that is equal 7.3. So the absence of ketone in the blood is about 1 millimole per liter. And once this has been achieved, then insulin can be switched to the usual oral regimen or the previous units that we're taking. For the common medication used in DKA, then the insulin and fluid are usually given as IV in an attempt to decrease the blood glucose by a percentage that is about 50 to 75 milligram per deciliter in each hour. And the guidelines can be recommended as a bolus with an initial large dose of insulin of about 0.1 unit per kg of the body weight if the potassium level was higher than 3.3. And also a regular of glycine and insulin are equally effective during the acute treatment phase of DKA, with a basal bolus regimen that has glargine and glycine, which is safer choice than the NPH, and the regular insulin after the resolution of the condition of DKA. Also, dextrose in a saline solution is given once the plasma glucose has decreased to avoid the accidental development of a hypoglycemic attack. For the potassium, the phosphate, and magnesium, their levels can be low and therefore should be monitored carefully. Also, bicarbonate therapy is needed only in rare cases, and an intravenous antibiotic therapy will be needed where there is sepsis with atypical antipsychotic, thiazide diuretic, and corticosteroid that can lead to DKA if the patient is not carefully monitored for their effect on the blood glucose values. In terms of using herbs, we should educate the patient that they shouldn't use any herb or essential supplement without consulting or discussing it with the physician first. For the nutritional education, we should explain the demands for more insulin during illness or the presence of an infection. And using diabetes record can be useful if the episodes of a high blood glucose are frequent. Therefore, this can be used as a helpful method to assess the usual blood glucose values throughout the day. Also, we should educate the patient to never exercise when there are ketones present. Because every episode of DKA can imply a breakdown in the clinical communication, then appropriate education should be reinforced accordingly and managing any holes or misleads in the educational process. So educating the patient and their social environment to promote a frequent testing, especially during the sick days where the patient is at an increased metabolic status, and also to lower their glucose level, as well as to recognize the early symptoms of hyperglycemia and decay, which is very important in preventing the development of severe decay. Also, when a strict control through insulin is administered, then weight gain is mostly common in most of the cases. Therefore, insulin omission and reduction, which are eating disorder symptoms unique to the diabetes mellitus, are mostly associated with an increased risk for DKA. So this condition mostly developed in adolescence, and therefore they should be monitored carefully for the occurrence of prohibited insulin omission. In addition, attention to this disorder is important in the overall treatment planning and also in the management. And the biggest risk of the insulin pump therapy is DKA, since there is no long-acting insulin that is used in such mechanism. Therefore, monitoring the machine mechanism of action is very important, as any interruption to the insulin delivery or the pump malfunctioning can result in the development of DKA. So to prevent this reaction, we should monitor the blood glucose regularly, and an insulin pump user also need to check often to see that the insulin is still flowing through the tubing properly. If the patient also was using tube feeding, then we should teach them on the appropriate sanitation and food handling procedure to avoid the occurrence of a foodborne illnesses. Another common complication of diabetes is the hyperosmolar hyperglycemic state. The diabetic HHS is a life-threatening emergency with a marked elevation of the blood glucose and also hyperosmolarity with minimal or even no ketosis. So this condition is preventable if the blood glucose is monitored regularly in order to correct the elevation levels before the problem can develop or occur. So the condition can occur in patients who are older than 70 and have type 2 diabetes, with a profound condition of dehydration as a precipitating factor for the development of this condition. So if it was recognized early, then HHS can frequently be treated in the outpatient setting if the patient can take fluid orally. And sometimes DKA is considered the first time that diabetes is diagnosed, and the identification with the treatment of the underlying and the precipitating cause of HHS are absolutely essential in all of the cases. The predisposing factors for this syndrome include a long-term uncontrolled hyperglycemia, pancreatic disease, infection or sepsis, with stroke, surgery, and extensive burns, all of which are precipitating factors for this condition. Also, renal or coronary vascular disease, corticosteroid use or using diuretic with an extensive use of total parenteral nutrition, and if the patient was on dialysis or having an underlying poor compliance with their medication or having infection or using substance, these are all the most common conditions for developing HHS syndrome. In addition, in children, using corticosteroid and gastroenteritis are the most common causes for developing this syndrome. And any person who has or developed this syndrome has a higher mortality rate of up to 20%. So the areas of future research can include a prospective randomized studies to determine the pathophysiological mechanism for the absence of ketosis in the presence of HHS syndrome, and also to investigate the reasons for the elevated pro-inflammatory cytokines and also the cardiovascular risk factors. In terms of the intervention, we should aim to correct the dehydration, the shock, and the cardiac arrhythmias, and also to reduce the elevated blood glucose level with using an isotonic saline, then a hypotonic saline, along with having insulin infusion to the patient. We should also monitor the fluid status and replace the deficient fluids, which can be about 10 to 20% of the total body weight. So this can require up to 9 liters of fluid in about 48 hours. Also, we should aim to prevent the future crisis by an appropriate DSME and a regular monitoring for the blood glucose. And we should prevent acute renal failure, which could result from a prolonged hypovolemic shock. For the nutritional intervention, we should offer the patient fluid replacement as 1 liter per an hour until the volume is restored. As we mentioned, the patient can require up to 9 or 12 liters in 48 hours. So in addition, the patient is likely to have MPO during a crisis or even perhaps tube feeding placement during a comatose status. And as appropriate, we should have the intake progress gradually to a balanced diet, then controlling the calories also depending on the patient condition and underlying cause for the HHS syndrome. We should also correct the electrolyte defects, and the potassium or magnesium can be needed as a supplemental dose, depending also on the patient condition. And the reported sodium level should be corrected when the patient's glucose level is markedly elevated. And in these circumstances, then an extracellular fluid osmolality can rise and even exceed that of the intracellular fluid. And since that the glucose can penetrate the cell membrane, then slowly, in the absence of insulin, this will result in the movement of water from out of the cells into the extracellular fluid. So the types of fluid that are administered will depend on the corrected serum sodium level. The corrected serum sodium level can be calculated through the following formula. The measured sodium divided or multiplied by the serum glucose in 100 divided by 100 and then multiplied again by 1.6. Also, a renal diet plan can be needed if a renal failure is identified in those patients. For the medications that are usually used, insulin is always needed to normalize the blood glucose level in the presence of an HH syndrome. Also, infusion will be needed until the full rehydration status is completed. And DKA and also HSS are always associated with an elevation of the pro-inflammatory cytokines. Therefore, insulin therapy can provide a strong anti-inflammatory effect for such conditions. In addition, potassium replacement can be needed and should be monitored carefully for any alteration, as it can result in negative effects on the CVD. And antibiotic therapy can be needed in cases of an underlying infection presence. And the drugs that can precipitate HHS syndrome include diuretic, beta blocker, clobazine, and olozapine with H2 blocker, all of which have the risk of developing this syndrome. For using herbs, also no herb should be used without discussing it first with the physician to assess if it has any side effect or negative implication on the blood glucose values. For the nutritional management, we should discuss, where possible, predisposing factors for developing this syndrome and how to avoid any future incidents, and also the blood glucose monitoring in all cases. In addition, the carbohydrate controlled diets can be beneficial if the patient can comprehend with family intervention that might be required to have a better implementation for the blood. We should also discuss the possible neglect or abuse if it was suspected in any pediatric patient. And the continuous management of fluid intake, electrolyte, and glucose disturbance is necessary until it is completely resolved. And we should provide diabetes teaching to prevent the reoccurrence of such condition in the future. Also, we should adjust the insulin or the oral hypoglycemic therapy on the basis of the insulin requirement once the serum glucose level are stable. And we should coordinate the home visit from nursing or the dietitian if it was needed to evaluate the inadequate access to water. Also, if the patient was using home tube feeding, then we should teach them on the appropriate sanitation and food handling procedure to avoid the development of any infections. Another major concern in diabetic patients is hypoglycemia. It usually occurs or primarily in patients with type 1 diabetes, and except in the diabetic patients who are receiving insulin or sulfonylureas, hypoglycemia is a rare disorder. And the true blood sugar value of 70 milligram or lower can release hormones such as catecholamines, which in turn produces hunger, trembling, headache, dizziness, weakness, and also palpitations. So the sources of the bodily glucose are either from dietary intake or glyconeogenesis and also gluconeogenesis. So the metabolism of the glucose can involve the oxidation and also the storage as glycogen or fat. And the body can make a great effort to supply the glucose for the CNS and also the red blood cells. In addition, glyconeogenesis is stimulated by secretion of glucagon from the alpha cells of the pancreas, as this is impaired in patients who have type 1 diabetes. And as the different causes can stimulate hypoglycemia, then the treatment will differ accordingly depending on the underlying cause for the hypoglycemia. Also, skipped or insufficient meals or error in the insulin dosing, taking too much insulin, or an extra physical activity, all can lead to the development of a hypoglycemic episode or attack. Also, an oxidative stress with zinc release can contribute to the neural death after hypoglycemia development. And the recurrent episode of hypoglycemia, that is idiopathic, can induce a state of hypoglycemia unawareness and also defective counter-regulation to prevent the lowering of the blood glucose, which is defined as hypoglycemia-associated autonomic failure. So it is essential to manage these episodes carefully. And the pro-oxidant status is promoted in certain brain regions during hypoglycemia and also after the glucose reperfusion, which can all result from the activation of several oxidative stress pathways. And the subsequent cell death can occur in particular in the brain region, including the cerebral cortex and the striatum with the hippocampus. Therefore, approaches to the prevention of hypoglycemia include glucose monitoring, patient education, meal planning, and medication adjustment, all of which should be implemented from the first stage of the diagnosis of diabetes to prevent the development of such complications. In addition, an adequate carbohydrate replacement during and after exercise seems to be an important measure to preventing hypoglycemia. And insulin doses adjustment with a decrease from 20 to even 30% is needed only for the cases of exercise duration that are more than 1 hour. In terms of the intervention, we should aim to normalize the blood glucose levels, and if the problem is recurrent, then stabilizing the blood glucose level through a consistent meal timing, carbohydrate consistency, insulin dose adjustment, and also blood glucose self-monitoring is necessary. And for individuals on insulin, then appropriate insulin timing with food or the use of carbohydrate to insulin ratio are always important factors to consider. We should also minimize the length of time between meals to prevent hypoglycemia between meals, and we should aim to prevent seizures and coma with the precipitating symptoms such as neuroglycopenia with confusion, lightheadedness, and also aberrant behavior. So determining the frequency and the symptoms of hypoglycemia and also the activity level for each individual are all helpful steps in preventing the development of hypoglycemic attack. And the delayed hypoglycemia after strenuous or even prolonged exercise can occur in up to 24 hours after an exercise, and it is also related to an increased insulin sensitivity from exercise as well as the repletion of glycogen stores. So planning appropriately by increasing the carbohydrate and decreasing insulin for periods of activity with also increasing the frequency of blood glucose monitoring are all indicated steps in this process. We should also always recheck the blood glucose level in about 15 to 20 minutes after the treatment to make sure that the problem is resolved. And a very low blood glucose level of about 50 grams per deciliter can take or require 30 grams of carbohydrate or even more to resolve, especially after a period of exercise. For the nutritional management, in an insulin-induced hypoglycemia, using a normal diet with an adequate carbohydrate content is recommended. And we should consider a possible reduction of medication if the hypoglycemia is recurrent. And we should have patients ingest fruit juice when needed or even use candy for an immediate corrective measure in the case of the development of a hypoglycemic attack. Also, if there are symptoms of hypoglycemia in which the blood glucose is about 70 grams per deciliter, we should advise the patient to have a quick source of glucose with them in order to avoid any future events of hypoglycemia. And as fat is not as effective as carbohydrate in normalizing the blood glucose, and in most cases of mild hypoglycemia, this can be handled with the use of a readily active or available carbohydrate, such as milk, fruit, and crackers, as the best option for treating hypoglycemic attack in a quick method. Also, a balanced regular mealtime or even frequent small snacks are useful to prevent the development of hypoglycemia. And in the cases of hypoglycemia at night, that is caused by excessive insulin or an insufficient dinner meal or even evening snack, then we should adjust the evening and the bedtime doses of the insulin to prevent the development of such conditions. Also, a slightly larger dinner or even snack containing carbohydrate can be needed in these situations to prevent also sleeping hypoglycemia. For medication that are commonly used as insulin and other glucose-lowering medication must be carefully prescribed and also monitored to assess for any requirement in adjustment of the dose. Also, careful use of the sliding scale of the insulin is the goal in the treatment, and a glycemic control to lower the blood glucose target range can be achieved using a computerized insulin dosing protocol with even particular attention to the timely measurement and also the adjustment of the dose. Using glucose tablets that have about 4 to even 5 grams of carbohydrate per each tablet is recommended in cases of hypoglycemia, and the patient should receive instructions regarding the quantity and when to use and also when not to use them. In addition, most people will need 3 to even 4 tablets to treat the low blood glucose values. And if the individual can passes out from hypoglycemia and uses insulin on a daily basis, then it can be necessary to give a glucagon shot and also call for emergency assistance in these cases. And glucagon can cause vomiting as a side effect, therefore, this should be carefully monitored. Also, an IV dextrose is administered by the medical professions to correct these conditions. In terms of using herbs, as discussed previously, some herbs or spices can have a severely negative impact on the blood glucose control. Therefore, no herb or supplement or potential supplement should be used without discussing it with their physician first, as clinical trials are lacking for this condition to have recommended doses or intake. In terms of the nutrition management and education, we should teach the patient the benefits of a frequent blood glucose monitoring, and we should explain to them the signs, the symptoms, and also the treatment of hypoglycemia. Also, we should review the appropriate timing of the meals, snack, and also the medications. And we should promote regular meal times, meal spacing, and also planned exercise. And we should teach the routine blood glucose before or even after exercise to monitor the blood glucose. And we should discuss carrying a quick source of glucose in cases for hypoglycemic attack. In addition, encouraging the patient to obtain and also to carry diabetes identification label is recommended. This is due to the occurrence or the sudden occurrence of hypoglycemia in some situations. We should also discuss the observation that require any medical attention. Also, teaching the patient when to contact the physician for medication adjustment is recommended. And in the elderly who are monitoring the blood glucose level closely, then the benefit of an intensive therapy in an effort to lower A1C can be or can outweigh against the greater risk of an unpredictable episode of hypoglycemia. Another important condition in diabetes is hyperinsulinism and the spontaneous hypoglycemia. Hyperinsulinism consists of insulin level that is above 3 units per milli when the glucose level are below 50 milligrams. And the treatment can depend on the cause and also on the severity of the hyperinsulinism. In the case of congenital hyperinsulinism condition, this is familial condition with a profound hypoglycemic attack due to the excessive insulin secretion in the body. The CH can lead to developmental delay, mental retardation, or even death if this wasn't treated immediately. Also, carbohydrate, CH, can occur at an approximate frequency of 1 in every 20,000 cases to even 1 in every 50,000 lifetimes. So the new procedures can spare healthy cells in the pancreas while allowing the surgeon to remove the abnormal tissue that causes the problem. While in the spontaneous hypoglycemic condition, there is an underlying symptoms of some other diseases besides diabetes itself, as fasting and reactive hypoglycemia can all fall into this category of the spontaneous form. While in the condition of fasting hypoglycemia, the body is not able to maintain adequate levels of sugar in the blood after a period without food or a period of fasting. So the people with the islet cell tumor can mostly have this condition, or persons who have viral hepatitis, cirrhosis, or even liver cancer, and also in children with carbohydrate metabolic disease. In addition, the hereditary fructose intolerance, the galactosemia, the leucine sensitivity, all of which can cause this type of hypoglycemia. Another condition is the reactive hypoglycemia. This describes the recurrent episode of hypoglycemia occurring in 2 to even 4 hours after a high carbohydrate or glucose load. So the symptoms can include weakness and also agitation in about 2 to 4 hours after the meal, respiration, nervousness, and also mental confusion. The etiology for this condition is that elementary hypoglycemia can occur in cases of dumping syndrome, for example, following gastric surgery. And hypothyroidism or other hormonal disorders, such as, for example, also infections, including the H. pylori-induced gastritis, all of which can lead to this condition. In addition, the occurred diabetes with an exaggerated hyperglycemia during glucose tolerance tests can lead to this condition. So diet remains the main treatment option, even though that the alpha-glucoside inhibitors and also some other drugs can be helpful in managing this condition. Also, the brain glycogen supports the energy metabolism when the glucose supply from the blood is inadequate and its level can rebound to even higher levels than the normal after a single episode of a moderate hypoglycemia. Also, glutamate can serve as an important intracellular signaling function, including the glutamate dehydrogenase catalyze the oxidative deamination of the glutamate and then converted to alpha-ketoglutarate in the brain, liver, kidney, and also in the pancreatic islet. For the intervention, we should aim to reduce the intake of the concentrated carbohydrate to a level that doesn't overstimulate the pancreas to secrete an inappropriately large amount of insulin, which can cause blood sugar to drop. We should also limit the total intake of carbohydrate to 130 grams per day to even reduce the severity of the symptoms. And if this was required, we should ensure the patient lose weight gradually if they were overweight. Also, we should reduce the counter-regulatory hormone response to the excessive insulin and exercise regularly, and also maintaining a consistency in meal timing and daily routine is necessary to control the patient's condition. For the nutritional management, the diet should include frequent small meals about every 3 hours to prevent the development of hypoglycemia. Also, the patient should be instructed to eat a variety of food, including meat, poultry, fish, and other non-meat sources of high protein. In addition, choosing a high-fiber food and food with moderate to even low glycemic load is recommended, and we should instruct the patient to avoid white rice, potatoes, and also corn. And we should ask the patient to avoid or even limit food that are high in sugar, especially on an empty stomach, as this can include sweetened beverage and also dried fruit. We should also instruct the patient to avoid caffeine and maintain protein intake at the recommended daily allowance levels with fats that furnish the remainder of the caloric requirement. So the traditional high protein, low carbohydrate diet is not evidence-based and shouldn't be recommended for the patients. And in the cases of glutathione D1 genetic form of the HI, then a low leucine diet and the use of dioscorides can be needed for the patient. And most of the other genetic forms can require surgery or even just medication use depending on the severity of the condition. For the common medications that are used, the dioscide is needed for the cases of glutathione 1 form of the HI, which is believed to inhibit the insulin secretion through the opening of the fat channels. Also, the octreotide, which is a somatostatin analog or the continuous dextrose, is often used in the patients, but also in the KATB of the HI, then the drug therapy will fail in most of the cases, and a pancreatectomy is required mostly. Also, chemotherapy can have some effect for the use in insulinomosa. We should also monitor the GI side effects and the nephrotoxicities, and the alpha-glucosidase inhibitors that can be diabetes is identified and be used. We should also monitor all medication for their potential hypoglycemic effect on the patient. For using herbs, products such as the hemicellulose and the pectin can be helpful in the cases of dumping syndrome, as these are all high in fiber in their content and can have or control the blood glucose value and the starch content in the food for a while. But other herbs and supplemental products shouldn't be used without discussing it with the doctor. For the nutritional management, we should ensure the patient keeps snacks available, such as cheese and cracker. Also, more frequent feeding are needed for the patients. We should also instruct the patient about avoiding skipping meals and eating meals in times in specific, and patients should avoid any one meal that is unbalanced or even especially high in carbohydrates. Also, controlling the caffeine intake and the use of other stimulants which can aggravate the condition should be monitored. And if the patient was using tube feeding, then we should teach them on the appropriate sanitation processes. The metabolic syndrome is a common condition in associating with diabetes. In this syndrome, it is an insulin-resistant syndrome or the syndrome X and has simultaneous clustering of the low levels of HDL cholesterol, the presence of hyperglycemia, and a high waist circumference with hypertension and elevated triglyceride levels. So any three of the following 5 criteria can indicate the diagnosis of a metabolic syndrome. The first is an elevated waist circumference of about 102 centimeters in men and 88 centimeters in women. Also an elevated triglyceride level or a drug treatment for the cases of elevated triglyceride can indicate this condition, and reduced HDL cholesterol of about 40 milligram in men and 50 milligram in women, or even if they were being treated for a low HDL values, then this can be as a criteria for metabolic syndrome. Also, an elevated blood pressure can be an indication with elevated fasting glucose values. So this condition is associated with CVD and can often lead to the development of type 2 diabetes. So this condition can affect some young people, but it usually affects people who are older than 55 years old. And more than 64 million Americans have metabolic syndrome, and roughly 1 in every 4 adults have, and about 40% of the adults aged about 40 years will have this condition. In addition, increased birth weight, excessive energy intake, or physical inactivity with obesity and even smoking, or the presence of inflammation and hypertension, all can contribute to the development of metabolic syndrome. So individuals who are obese and also insulin resistant are considered at a risk for developing this syndrome. And persons who have an apple-shaped body with a high waist circumference is considered at a higher risk because of the fat cells that are located in the abdomen, which release fats in the blood more easily than the fat that is found elsewhere in the body. So the levels are associated with sensitivity, and they are decreased in type 2 diabetes and also in obesity cases. So the genetic and the environmental factors can also contribute to the risk of this condition. And the initial insult in adipose inflammation and also insulin resistance is perpetuated through the chemokine secretion, the adipose retention of the macrophage, and also the elaboration of a pro-inflammatory adipocytokines. So in females, depressive symptoms are associated also with metabolic syndrome, especially in the elevated of the afternoon and the evening cortisol values. So more research is needed to understand how this disease or syndrome more effectively work, but there are some regular or general guidelines on its diagnosis. So the management of metabolic syndrome should focus on the lifestyle modification, especially reducing the caloric intake and also increasing the physical activity. In addition, the phytochemicals, the monounsaturated fatty acid, antioxidant food, and spices such as turmeric and cumin and cinnamon, all which have an inflammatory effect that can be also the intake of whole milk or even yogurt, calcium, and magnesium can protect against the development of metabolic syndrome, where the intake of cheese and low-fat milk and phosphorus doesn't have a protection factor. For the intervention, we should reduce the inflammatory status and also the insulin resistance that is caused by an excessive adipose tissue. And we should improve the body weight and reduce the abdominal obesity in particular. In addition, a realistic goal for weight reduction should be between 7 to 10% over a period of 6 to 12 months. And we should promote physical activity when indicated and recommendations that include a practical, regular, and even a moderate regimen of exercise with daily minimum intake or activity level of 30 to even 60 minutes, and also an equal balance between the aerobic and the strength training is recommended. So we should achieve and maintain the cholesterol and the blood glucose and also the blood pressure values at a level that is indicated by the American Heart Association as the following. For the atherogenic dyslipidemias, in the case of an elevated LDL cholesterol, then we should give priority to the reduction of LDL cholesterol over other lipid parameters, and we should achieve LDL cholesterol goals that are based on the individual patient risk categories. And in the LDL cholesterol goals for the different risk categories are as the following. In the high at-risk patient, we should have a value between 70 to 100, where in the moderate high risk, we should be between 100 to 130, and in the moderate risk, 130 is a reasonable level, while in the lower risk cases, then 160 is considered as a reasonable value. And in regard to the triglyceride values, if it was more than 200 milligram, then the goal for the non-HDL cholesterol for each risk category is 30 milligram per deciliter and higher than that for the LDL. While if the triglyceride was 200 after normalizing the LDL cholesterol, then we should consider additional therapy to attain an HDL cholesterol goals. Where if the HDL cholesterol is 40 milligram in men or 50 in women, then a raised HDL cholesterol or to the extent that is possible with standardized therapy for atherogenic dyslipidemia is recommended. And either a lifestyle therapy that can be intensified or drug therapy can be used for the cases of a high HDL, of raising HDL cholesterol level, depending, of course, on the patient risk categories. For the cases of an elevated blood pressure, we should reduce the blood pressure to at least achieve blood pressure of about 140 over 90, and we should reduce it further to the extent possible through lifestyle changes. And for blood pressure that is 120 over 80, then we should initiate or even maintain lifestyle modification through weight control, increasing physical activity, the sodium reduction, and also we should emphasize on increasing the consumption of fresh fruit, vegetables, and also low-fat dairy products in all of the patients. While if the blood pressure was 140 over 90, then or if the patient is diabetic, then we should add blood pressure medication as needed to achieve the goal blood pressure. And in the cases of elevated blood glucose value in the impaired fasting glucose, this can be helpful in delaying the progression of type 2 diabetes by encouraging weight reduction and also increasing the physical activity. Also, if a diabetic patient and the hemoglobin A1C is at or above 7%, then lifestyle therapy and pharmacotherapy, if necessary, should be used. And we should modify other risk factors and behaviors such as abdominal obesity and sedentary lifestyle, or even the presence of a high blood pressure or lipid abnormalities. And in the case of a prothrombic status, then we should reduce the thrombotic and the fibrolectin risk factors, and a low dose of aspirin therapy or even prophylaxis is recommended in these cases. Also, in the pro-inflammatory state, there are no specific therapy beyond lifestyle modification, and the use of antioxidants with omega-3 fatty acid can be helpful in some of the cases. For the nutritional management, the general recommendation include low intake of saturated fat, trans fat, and cholesterol. Also, increasing the use of omega-3 polyunsaturated fatty acid and the intake of monounsaturated fatty acid, in specific, the extra virgin olive oil. Also, we should plan Mediterranean type diet using more fiber and starches, especially the whole grains, the raw fruit, and vegetables. Also, a plant-based diet can be useful, and using DASH diet that contain about 4 grams of sodium with good source of potassium, calcium, and magnesium is recommended. In addition, the dairy product can provide a source of calcium, magnesium, and potassium and should be used in the diet. We should also monitor the patient's blood glucose levels, and in the case if they needed a carbohydrate restriction, it has been shown to improve the dyslipidemia that are associated with the metabolic syndrome, more than that of a low-fat diet. So we should also encourage a soy protein as a meat substitute several times in a week, as the soy protein can help against or with weight reduction and against the dyslipidemia. In addition, we should ensure the patient has adequate intake of folate, vitamin B6, 12, C, and also E, and preferably from food choices, not as a supplement. Also, dark chocolate in small amounts in a regular basis can help in lowering the blood pressure, improving the cholesterol, and help with the insulin sensitivity. We should also spread out the energy load throughout the day by eating small, frequent meals. For the medication to lower the lipids, statin should be used initially unless it is contraindicated. Also, statins can decrease the biomarkers of inflammation and oxidative stress in a dose-related manner, and also atorvastatin, about 80 milligrams compared with 10 milligram dose, is considered superior for decreasing the oxidized LDL and the matrix of the metachloramine and NF activity. So the glucose-lowering medication must be carefully prescribed and monitored to assess the patient's response, and metformin can be indicated for some of the cases. Also, the blood pressure medication can be prescribed but should be monitored for necessary restriction in the future, including the sodium or the higher need for potassium. Also, an ACE inhibitor or an angiotensin receptor blocker is usually the first medication of choice in these cases. In addition, medications that diminish the insulin resistance and directly alter the lipoprotein are necessary, but a combination therapy is often required. Also, if the patient with the metabolic syndrome have an elevated fibrinogen and other coagulation factor that is leading to prothrombic state, then aspirin is used. In addition, a low dose of aspirin is not generally a problem when it is taken with meals or even light snacks to prevent the potential for GI bleeding. In terms of using herbs, antioxidant supplements in specific are not recommended, but the intake of an antioxidant-rich food should be suggested. Therefore, trials with the alpha tocopherols have been disappointing, but further trial with the gamma and the alpha tocopherols are warranted to assess the exact effect of antioxidant on the general condition. Also, we should include phytochemicals, antioxidant food, and spices such as turmeric, cumin, and cinnamon in the diet. Also, chromium perchlorate, which enhances the insulin action by lowering the plasma membrane cholesterol level, is recommended for use. And the coenzyme Q10 can have some merit effect of enhancement, but further research is needed to determine its exact effect. Also, a high serum selenium concentration have been associated with the prevalence of a higher fasting blood glucose, LDL triglyceride, and the glycosylated hemoglobin level. But further research is also needed to determine its role in the development or even in the progression of metabolic syndrome. In addition, other herbs and potential supplements shouldn't be used without discussing it first with the physician. For the nutrition counseling and management, the widespread screening is recommended to slow the growth of this syndrome. And prevention should start in childhood with a healthy nutrition, daily physical activity, and also annual measurement of the weight, height, and blood pressure beginning at 3 years of age. We should also discuss the role of nutrition such as DASH or Mediterranean diet in managing this syndrome. In addition, obesity is a major contributor to the problem. Therefore, weight loss, even about 10 pounds, can help in improving the general health status. And the diet that is rich in oxidant, antioxidant, and DHA is beneficial. And finally, according to the 2005 dietary guidelines, these are consistent with lowering the risk of metabolic syndrome if they were implemented correctly. In addition, regular physical activity can help to lower the elevated blood cholesterol levels and the blood pressure. Also, walking or an exercise that is pleasant for the individual is one of the best to select as a long-term determinant for the health that is easier to adapt. And aerobic and strength training exercise are beneficial by reducing the sedentary activities, including television and computer time. In addition, smoking cessation measures can be needed to improve the overall health, and offering guidance on how not to gain weight after quitting is required. For the food-borne illnesses patient education, if the patient is home tube feeding, then we should teach them on the appropriate sanitation processes and food handling procedures. So we will be taking a break now for al-Maghrib prayer and then continue with COVID and diabetes. Welcome back, everyone. So now we'll start by discussing COVID-19 infection in people with diabetes who have either previously recognized or unrecognized diabetes. So in general, this can increase the risk of the emergency state of the hyperglycemia with the presence of ketones and also diabetic ketoacidosis with hyperosmolar hyperglycemic state. So being acutely unwell with a suspected or confirmed COVID-19, this requires adjustment to the standard approaches to diabetes management. So in the early admission state, people with COVID-19 infection appear to have a greater risk of hyperglycemia with ketones, including people with type 2 diabetes who have a risk of even greater if their SGLT2 level, they are using SGLT2 inhibitors. Also, people with a newly diagnosed diabetes are at increased risk. So COVID-19 disease can precipitate a typical presentation of diabetes emergencies. And in this case, the suggested action include checking the blood glucose in everybody on admission, and also checking the ketones if the patient has diabetes or in anyone with admissions who have a glucose over 12 millimole. We should also stop using SGLT2 inhibitors in all patients who are admitted to the hospitals, and we should consider using a 10 to even 20% glucose where ketones can persist despite treatment in line with the usual protocol. So in severe illnesses on admission, the fluid requirement can differ in those with DKA and HH syndrome, and also in those who have evidence of a lung leak. So in these cases, after restoring the circulating volume, the rate of fluid replacement regimen may need to be adjusted where the evidence of a lung leak or myocarditis is present. Also, we should contact the diabetes specialist team early on with early involvement of the critical care team. So in all inpatient areas, the infusion pumps cannot be available to manage the hyperglycemia using IV insulin as these required elsewhere, for example, in sedation in the ICU. لا التحضير مو لازم بعد كل بريك مرة واحدة وخلاص. So the suggested action in these cases are using an alternative sliding scale regimen to manage hyperglycemia and mild cases of DKA. Also, we should contact the diabetes specialist team for support. While in an ICU setting, the significant insulin resistance that are seen in patients with type 2 diabetes in an ICU setting is difficult to manage. So an IV insulin protocol may need amending for people who are even requiring up to 20 units of insulin per an hour. So the patient often nursed prone to feeding can be accidentally interrupted. So this can have a risk of hypoglycemia. And accordingly, a COVID-19 infection with patients who have diabetes can increase the risk of emergency status or hyperglycemic attack and ketoacidosis. So in regard to the management of the acute diabetes at the emergency, first we should conduct a patient assessment of ABCDs, as we should note for shortness of breath, which can also be due to a metabolic acidosis such as DKA. In addition, we should ensure that all newly admitted patients are evaluated for diabetes and glucose measurement in all patients, and also ketone check if the patient is known to have diabetes. Also, we should, as we mentioned, stop the SGLT2 inhibitors and the metformin in all patients. And we should review the safety of continuing ACE inhibitors, ARBs, and NSAIDs. In addition, the blood glucose level advice should be as the following. As the glucose is less than 4, then this indicates hypoglycemia, and we should follow the guidelines for management of hypoglycemia, where if it was more than 12 or a known case of diabetes, then this should be followed urgently to consider the following. A DKA, which is defined as glucose more than 11 or history of diabetes and blood ketones of more than 3 millimole. And in this case, we should note that the glucose can be normal in patients using SGLT2 inhibitors and associated with the presence of a DKA and pregnancy DKA. So it can mask the condition. So in an HH syndrome, the blood glucose is more than 30 with serum osmolarity that is more than 320. In addition, we should follow the guidelines if either of the previous mentioned is confirmed and to involve the diabetes care team to have the appropriate intervention. And we should note that we should never stop the basal insulin in persons with a known type 1 diabetes or DKA that can result as a consequence of stopping the basal insulin. Some other urgent causes that can lead to hyperglycemia, which we need to consider, is the new presentation of a diabetes, either type 1 and 2, and weight that is irrelevant for either one of them, including an extremely overweight person in type 1. Also, the presence of sepsis, for example, in a COVID or foot infection case, and a missed or even delayed usual diabetes treatment, including insulin, or a pump problem. Also, the reflection of uncontrolled diabetes and inappropriate treatment regimen. Also, we should consider if the patient is using oral steroid medication, and resistantly if the patient has high glucose levels that may need treatment with a subcutaneous or an intravenous insulin. Also, if an infusion pump is not available for IV insulin, then we should seek an advice regarding an alternative subcutaneous regimen method. And in all cases, we should follow the guidelines for the management of diabetes accordingly. For blood ketones level, if the blood ketone is less than 0.6 millimole, then this is considered the safe level, while if it was between 1.5 to even 2.9, this is at an increased risk for DKA, and treatment should be per oral or via IV fluid, and we should consider using rapid-acting insulin if the glucose is above 60 millimole, with 1 unit of rapid-acting insulin that is typically expected to lower the glucose by anywhere between 1 to even 3 millimole. After administration, we should recheck it after 2 hours. And if the blood ketone level is 3 millimole or greater, then we should check the patient pH levels and bicarbonate, and also DKA confirmed if the ketones are accompanied by one of the following: blood glucose of more than 11 millimole, or the patient have history of diabetes. In addition, a pH of less than 7.3 or a bicarbonate less than 15. But we should note that the glucose can be less than 11 if the patient is using SGLT2 medication inhibitors, and if the patient was pregnant or has a severe COVID-19 infection. For the insulin advice, we should always ask if the patient is using insulin or not, and we should always continue to use the basal long-acting insulin and never stop it. And patients who are very sick or not eating should have a variable rate of IV insulin infusion with usual basal subcutaneous insulin that is continued alongside. And if an infusion pump is not available for IV insulin, then we should contact the diabetes team and follow the local guidelines. In addition, in a patient who are using a wearable diabetes technology and they are unable to manage their personal insulin pump, or there is no specialist advice that is immediately available, then we should start the VRLL or the sliding scale basal bolus insulin regimen, and then we should afterward remove the pump and store it safely for forward use. And if an SC regimen is being required and not able to find out the total daily insulin dose from the pump itself, then we should follow the following. We should start by calculating the total daily insulin dose using 0.5 units per kg. Also, we should give half of the total dose as a basal background insulin and half of the other bolus dose as a bolus mealtime rapid-acting insulin. This is an example of how to calculate the units, and after calculating them, we should give half of the dose as basal insulin and the other half as a bolus insulin divided for each meal, for example, 5 units for each meal. Also, we should ensure that the pump is disconnected after this SC basal insulin that is given. In addition, the continuous glucose monitoring and the freestyle Libra devices can be left on the patient, but a conventional capillary glucose monitoring will still be necessary if needed. Also, for imaging, the insulin pumps and the continuous glucose monitoring with the freestyle Libra device can need to be removed for any magnetic scan, such as MRI. In regard to foot care, we should always need to exclude any acute foot infections, as these can be a source for sepsis or even a critical lump ischemia. In addition, we should always ensure that foot is intact and protected, and we should take action on an acute foot disease as per the local diabetes foot protocol. Some of the risk factors for hypoglycemia include the presence of medical issues, such as strict glycemic control, a previous history of severe hypoglycemia, or a long duration of having type 1 diabetes, or even a duration of insulin therapy in type 2 diabetes with lipohypertrophy at injection site, or even if the patient has an impaired awareness of hypoglycemia. Also, a severe hepatic dysfunction and an impaired renal function, all of these can include the causes for hypoglycemia, in addition to sepsis or an inadequate treatment of a previous hypoglycemic attack, and patients having cognitive or dysfunctional dementia. In addition, some lifestyle factors can also contribute to the development of hypoglycemia. These can include increased exercise or irregular lifestyle and increasing of the age, or even early pregnancy and the cases of breastfeeding or even if the patient is having inadequate blood glucose monitoring. In addition, reduced carbohydrate intake or absorption can also lead to hypoglycemia and food malabsorption, such as in gastroenteritis or celiac disease, and even bariatric surgery that involve a bowel resection, all can lead to hypoglycemia. In addition, a multivariable logistic regression analysis has showed that people aged more than 70 have a cognitive dysfunction and also nephropathy were independently associated with the occurrence of hypoglycemia as a recurrent condition. So we should be aware of the following that can also precipitate the development of hypoglycemia. A concurrent use of medications with hypoglycemic agents such as warfarin or brates or sulfonamide, all of which can lead to hypoglycemia in some of the cases. Also, we shouldn't stop or withhold any medication, but we should discuss it with the medical team to ensure adequate adjustment. And the loss of a counter-regulatory hormone function, such as in the cases of Addison disease or a growth hormone deficiency, can also cause hypoglycemia. Some of the potential causes for inpatient hypoglycemia include the following. As a misreading of a poorly written prescription, when, for example, unit is used for unit while it become 40 units. So this is a common mistake. Also, the confusion of the insulin name with the dose itself, as for example, homolog mix 25 can become homolog 25 unit. And also confusing the insulin strength with the dose itself as a 100 unit dose of individually prescribed. Also, the transcription errors, such as if the patient is on an animal protein insulin, or an inversely prescribed human insulin, where the handwriting is unclear. Also, an inappropriately withdrawn insulin using the standard insulin syringe from the pre-lit insulin pen can contain some higher concentrations, and also confusing between the prescription of a glucose and insulin can lead to higher dose and the development of hypoglycemia. So as we were saying, the potential causes of inpatient hypoglycemia could also include some medical conditions, including a change in the insulin injection site, for example, an IV infusion with or even without glucose infusion, And in the cases of inadequate mixing of the intermediate acting or the mixed insulin use, in addition, regular insulin doses or oral hypoglycemic therapy can be given in hospital when these are not routinely taken at home and can lead to more effect on the patient. Also, some carbohydrate intake issue can lead to inpatient hypoglycemia. These can include a missed or even delayed meal or less carbohydrate intake than the usual, and a change of the timing of the biggest meal of the day. For example, if they were consuming the main meal at the midday rather than in the evening. Also, in the cases of lack of access to the usual between meals or before meal snack, all of which can affect the patient glycemic control. Also, if the patient is usually taking bedtime snack or having a prolonged starvation time in the hospital, as in the cases of MBO, or if the patient has vomiting or even reduced appetite due to illness and reduced carbohydrate intake in general. Also, omitting the glucose while on IV insulin infusion can lead to hypoglycemia. In terms of morbidity and mortality, hypoglycemia can cause severe complications such as coma and hemiparesis or even seizures. So if the hypoglycemia is prolonged, then the neurological defect may become permanent. And acute hypoglycemia can impair many aspects of the cognitive function, in particular those involving planning and also multitasking. Also, the long-term effect of a repeated exposure to a severe hypoglycemia is less clear at this stage. In addition, the study has highlighted a potential risk of intensive glycemic control, which can have an adverse effect on the blood glucose. In addition, a recognized and unrecognized hypoglycemia was more common in the intensive group than in that of the standard group. And in the intensive group, a small but statistically significant inverse relationship of an uncertain clinical importance was identified between the number of hypoglycemic episodes and also the risk of death among the participants. And the patient on the insulin therapy remained in hospital for a longer period if they experienced a hypoglycemic attack. So this is accordingly 7 days compared to 4 days in those who didn't experience any hypoglycemic attack. In addition, patients on insulin therapy also had greater inpatient mortality if they experienced hypoglycemia compared to those who didn't have any hypoglycemia. So the inpatient mortality rate increased to about 25% in patients with hypoglycemia that is defined as less than 2.2 millimolar. In addition, it was examined that the data from over 4,000 admission episodes of people with diabetes, which represented that about 1/3 were on regular insulin therapy and didn't have complications. So the patient who experienced inpatient hypoglycemia had about 66% increased risk of death within the first year that was spent even longer days if we stay in the hospital. Also, an increased mortality rate were reported for inpatients who were using insulin therapy and experienced hypoglycemia. And about 50% of the participants had diabetes, and subgroup analysis of those with diabetes would have been useful for more accurate or reliable data. Also, in the case of an impaired awareness of hypoglycemia, which is defined as an acquired syndrome that is associated with insulin treatment, this syndrome results in the warning signs of or symptoms of hypoglycemia becoming diminished completely in the intensity, with altering the nature or even lost together for detecting the symptoms of hypoglycemia. So this can increase the vulnerability of the affected individuals of progressing to severe hypoglycemia, and the prevalence of this condition or syndrome increases with the duration of diabetes, and it is much more common in type 1 than in those having type 2 diabetes. In terms of managing hypoglycemic episodes in a hospital setting, as people experiencing hypoglycemia will require quick-acting carbohydrate to return to their normal blood glucose level after having hypoglycemia or hypoglycemia. So the quick-acting carbohydrate should be followed by giving a long-acting carbohydrate either as a snack or as a part of the planned meal. In addition, all patients experiencing hypoglycemia should be treated immediately without any delay to prevent the worsening of the condition. And where it is safe to do so, a blood glucose measurement should be taken to confirm hypoglycemia. And if the measurement is difficult, for example, in patients undergoing a seizure, then treatment shouldn't be delayed at any point. While if the measurement was difficult, such as in patients undergoing seizure, then the treatment should be delayed. So after acute treatment, the consideration should be given to whether the hypoglycemia is likely to be prolonged, as for example, the result of a long-acting insulin or due to sulfonylurea therapy, as these patients can require continuous infusion of the glucose to maintain the blood glucose levels. Also, normal blood glucose level in a person without diabetes is between 3.5 to 7 millimoles. In addition, to avoid the potential hypoglycemia, the Diabetes UK recommends a practical policy of making for the OR, which is a 4 millimole, which is the lowest acceptable blood glucose level in patients with diabetes. In addition, a regular blood glucose monitoring can enable the detection of asymptomatic biochemical hypoglycemia. So evidence for treatment options, as there is limited evidence regarding the quantity of the quick-acting carbohydrate which is required to successfully treat an episode of hypoglycemia. So the initial quantities that are chosen were the result of expert opinion which is backed up by glucose clamp studies. So a study has compared giving 15 gram versus 20 gram and found that about 60% of the episode resolved after one treatment of 15 gram of carbohydrate. While another studies that used a continuous glucose monitoring of about 100 adult patients over 6 days, they didn't have adequate treatment as the ingestion of 20 grams of quick-acting carbohydrate was sufficient. And they reported that about 30% of hypoglycemic episodes were undertreated. Also, participants who were undertreated had about 50% chance of remaining hypoglycemic at the repeat test, which is compared to 30% for those who were adequately treated. So this reinforcement with the suggestion that the treatment of hypoglycemia with any dose that is less than 10 grams of quick-acting carbohydrate is likely to be inadequate and will need to be re-administered again to have the required blood glucose level. And overtreatment of hypoglycemic episodes is often seen in both the community and also in the hospital setting. And about 73% of hypoglycemic episodes were overtreated with more than 20 grams of rapid-acting carbohydrate in adults who have type 1 diabetes. Also, previously, chocolate was recommended as a treatment for hypoglycemia, but it is not recommended anymore because it can contain a quick-acting carbohydrate and a fat source, and the fat will have a lower effect due to, on the blood glucose value. So orange juice remains a popular treatment for hypoglycemia for a quick-acting carbohydrate source. So the total sugar content of any fruit juice varies according to the ripeness of the fruit, the season, and also if they were added any sugar or any other additive. Also, a more recent study has shown that fructose in the form of a fruit bar was less effective than the sucrose that is successfully treating hypoglycemia in children with type 1 diabetes. And by contrast, a recent study found that people or children with type 1 diabetes who attended diabetes camp found that orange juice to be a reliable or effective treatment option. So several studies have examined the time interval between treatment and also retesting to confirm the resolution of hypoglycemia. And all are supportive of a minimum interval of at least 10 minutes before retesting to ensure the resolution of hypoglycemia. So another study concluded that repeating carbohydrate intake every 5 to 10 minutes wouldn't allow adequate time for the treatment to take an effective result or impact on the blood glucose value. And another study has reported that when hypoglycemia was treated with 20 grams of carbohydrate, then 55% were adequately treated only after 5 minutes. So evidence for a parenteral treatment option as intramuscular glucagon and intravenous glucose in varying concentration are considered the main treatment option. And a randomized trial of people attending the emergency department with hypoglycemia, they found that the glucagon almost as effective as an intravenous dextrose with no difference in the adverse events. Also, a faster recovery of the blood glucose level using IV glucose compared with intramuscular glucagon was shown in 2 studies with subsequent effect on the blood glucose level. Also, the glucagon will be less effective in people with depleted glycogen reserve, such as those in the cases of impaired hepatic function. Therefore, in summary, the glucagon is effective and can be a useful treatment option, especially outside the hospital setting when an IV access may not be available. But it can also only be used once with the slower recovery and also the higher treatment failure rate, which make an IV glucose the preferred option. So the increment in the blood glucose after administration of 50% of glucose can vary widely between individuals with hypoglycemia. So the mean increment in participants who have diabetes was about 9 millimoles, with a larger standard deviation of about 4 millimoles. Also, a study that administered 5 grams of aliquots of either 10 or 15% glucose at 1 minute interval in patients who have hypoglycemia until they recover their consciousness level had a better result. And accordingly, using 10% glucose resulted in a lower post-treatment glucose level. And 10 grams of carbohydrate that were delivered as 10% dextrose in the pre-hospital setting resulted in adequate treatment for hypoglycemia. In addition, the risk of exacerbation of an injury that is due to any hypertonic solution can make about 10% dextrose as a safer choice than the 50% glucose. Also, glucose 10% preparation are considerably less hypertonic than the 50% preparation and has a less destructive effect on the venous endothelium. A study using rabbit ears found that the increasing duration of the infusion has resulted in decreasing the tolerance of the peripheral venous to solution, which increased the osmolarity. So for these reasons, a 10 or even 20% glucose solution are the preferred and the safe option. And alternation to the treatment regimen with the aim of reducing hypoglycemic attack with the therapeutic interior can make the healthcare professional slow to respond to hypoglycemic event, or to even proactively reduce the insulin dose in our patients who are identified as at risk for hypoglycemia. So there is evidence that the implementation of a hypoglycemic reduction bundle in a hospital environment can also reduce the rates of hypoglycemia. So for treatment in inpatients who are conscious and able to swallow, giving the patient 15 to even 20 grams of fast-acting carbohydrate is the preferred treatment method. And subsequent treatment algorithm that discuss the treatment option for those who are unable to consume oral carbohydrate is recommended. As adults who have poor glycemic control can start at experience symptoms of hypoglycemic attack of a level that is above 4 millimole. But there is no evidence that their threshold for the cognitive dysfunction are at risk upward. Therefore, the only reason for the treatment is asymptomatic relief. So in adult patients who are experiencing hypoglycemic symptoms but have a blood glucose level more than 4 millimole, then we should give them small amount of carbohydrate snack in about, for example, 1 medium banana or 1 slice of bread. And all adults with a blood glucose that is less than 4 millimole with or even without symptoms of hypoglycemia should be treated as outlined before by giving them 20 grams of carbohydrate. So the dose adjustment for the normal eating is, of course, for people with type 1 diabetes and designed for them to detect the signs of diabetes, and therefore should be recommended to be implemented from early diagnosis. But in a hospitalized patient, the Joint British Diabetes Society for Inpatient Care suggests that the target blood glucose level is 6 to 10 millimole. So this recommendation that in the hospital environment, a blood glucose of less than 4 is treated as hypoglycemia in all patients who have diabetes. Therefore, a continuous subcutaneous insulin infusion or insulin pump that can administer a rapid-acting insulin on a continuous basis via subcutaneous cannula is the recommended choice for patients with type 1 diabetes. But if the hypoglycemia reoccurs, then a long-acting carbohydrate must be given after the initial treatment, and the patient should be referred to the diabetes inpatient specialist team. So, in hypoglycemic inpatient, even though that most patients with diabetes are admitted for reasons that are not directly related to their diabetes, an adequate management of their case while an inpatient, including the timely recognition, the treatment, and the prevention of hypoglycemia, can help in reducing the morbidity and also reducing the length of inpatient stay. So these guidelines are intended to guide in the assessment and the management of hospital inpatients with diabetes, but each patient should be individually assessed and managed according to their condition. And many patients with diabetes will carry their own supplies of their oral carbohydrate for the cases of hypoglycemia and should be supported to self-manage their condition when they are capable. So the patients who are capable of self-caring should alert the nursing staff with that they have an episode of hypoglycemia that has occurred and they managed it themselves. So many episodes of hypoglycemia are avoidable, so every preventable measure should be taken to avoid them. And an easily accessible, quick, and long-acting carbohydrate must be available in the clinic area and in the emergency unit. So we'll be taking a break now for a leisure break, and then we will continue with managing hospitalized diabetes patients. Assalamu alaikum wa rahmatullah. Welcome back, everyone, in the last section of our webinar. So now we'll be discussing how to manage hospitalized patients with diabetes. In terms of adults who are conscious and oriented with ability to swallow. In this case, we should start by giving the patient a 15 to 20 gram of a quick-acting carbohydrate, depending on the patient's choice. Some of the examples can include dextrose tablet or a bottle of glucose juice, or even pure fruit juice. So when managing patients following a low potassium diet, for example, due to chronic kidney disease, we shouldn't use any orange juice to treat hypoglycemia due to its potassium content, which can have some negative effect on the patient. Also, sugar that are dissolved in water is not an effective treatment for patients who are taking acarbose, as it can prevent the breakdown of sucrose to glucose. So it should also only be considered if there are no other treatment option readily available. We should then repeat a capillary blood glucose measurement about 10 to 15 minutes later. And if it is still less than 4 millimole, then we should repeat the step 1, but we shouldn't repeat it for more than 3 times. While if the blood glucose remains less than 4 millimole after about 45 minutes or even 3 cycles, then we should contact the doctor to consider the following: giving the patient a 1 milligram of glucagon intramuscularly. That can be less effective in patients who are using sulfonylurea therapy. Or they could give the patient about 200 milli or 10% glucose over 15 minutes. Also, care should be taken with infusion pumps sitting if the larger volume bags are being used to ensure that the whole bag is not inadvertently administered. Also, volume should be determined by the clinical circumstances of the patients. And once the blood glucose is above 4 millimole and the patient has recovered, then we should give a long-acting carbohydrate of the patient's choice where it is possible. And we should take into consideration any specific dietary requirement. Some of the examples can include giving the patient bread or a glass of milk. Also, we should note that the patients who are receiving glucagon will require a larger portion of the long-acting carbohydrate to replace the glycogen stores. Also, we should double the suggested amount above or previously mentioned, even though that nausea associated with glucagon injection can be an issue. Also, we shouldn't omit insulin injection if the time is due, but the insulin regimen review can be required if the patient is suffering from repeated hypoglycemic attack. Also, in patients who are self-managing their insulin pump, they may not need a long-acting carbohydrate, but they should take an initial treatment as outlined and adjust their pump setting appropriately. And many of the patients will have a locally advised hypoglycemic protocol that should be checked to ensure that it remains appropriate for use in the inpatient setting. In addition, if the hypoglycemia was due to sulfonylurea or a long-acting insulin therapy, then we should be aware that the risk of hypoglycemia can persist for up to even 36 hours following the last dose that was administered. This is especially if there is a concurrent renal impairment with the patient. We should also document the event in the patient notes, and we should ensure a regular capillary blood glucose monitoring is continued for at least 24 to 48 hours. Also, we should ask the patient to continue this at home if they are to be discharged, and we should give them a hypoglycemia education or refer them to the local diabetes inpatient team. In the case of an adult who is conscious but confused and disoriented with the inability to collaborate, or who is aggressive but still able to swallow. So in this case, if the patient is capable and cooperative, we should follow the previously mentioned guidelines. While if the patient is not capable or uncooperative, but can swallow, then we should give them either 1 to even 2 tubes of 40% glucose gel, the glucogel, that is squeezed into the mouth between the teeth and the gum. Or if this is not possible, we should give the patient a glucagon of an intramuscular injection that can be less effective in patients who are prescribed sulfonylurea therapy. We should also repeat the capillary blood glucose levels after 10 to 15 minutes. And if it is still less than 4, then we will repeat the first and the second step. But we shouldn't have more than 3 treatment cycles in general, and only give intramuscular glucose injection once only in each patient. So if the blood glucose level is still less than 4 millimole after 45 minutes, we should consider an intravenous glucose of about 10% glucose over 15 minutes, or we should take care in taking the infusion pump setting if the larger volume of the bags are being used. This is to ensure that the whole bag is not inadvertently administered, and the volume should be determined by the clinical circumstances of the patient. And once the blood glucose is above 4 millimole and the patient has recovered, then we should give them a long-acting carbohydrate of the patient choice where possible, and we should take into account that any specific dietary requirement they have. We should also note that if the patient who is given glucagon require any larger portions of a long-acting carbohydrate to replace the glycogen stores, and if the patient who is self-managing their insulin pump may not need a long-acting carbohydrate, but also should take initial treatment and continue their pump, and also assess for the causes of the episode. We shouldn't also omit the insulin injections if the time is due, but the insulin regimen review can be indicated. Also, in patients who are self-managing their insulin pump, they may not need any long-acting carbohydrate, but should take the initial treatment as outlined previously and adjust their pump accordingly. In addition, many patients will have a locally advised hypoglycemia protocol that should be checked to ensure they are following the guidelines. Also, if the hypoglycemia was due to sulfonylurea or any long-acting insulin therapy, then we should be aware that the risk of hypoglycemia can persist for up to 24 or even 36 hours following the last dose, especially if there was any concurrent renal impairment. We should also ensure that we document the event in the patient note, as this can ensure regular capillary blood glucose monitoring that is continued for at least 48 hours. And we should ask the patient to continue this at home if they are able to be discharged, and give them a hypoglycemia education or even refer them to diabetes inpatient team. In the case of adults who are unconscious or having seizures or very aggressive. In this case, we should check the patient airways and give them oxygen if it was required. Also, we should therefore check their breathing, their circulation, and if they have any disability, including the GCS score, and also the blood glucose and their exposure, including their temperature. And if the patient has an insulin infusion, then we should stop that immediately. And we should request immediate assistance from the medical staff as with the fast bleed doctor. Also, the following three options are all appropriate and local agreement should be sought, where if an IV access is available, then we should give the patient about 100 ml of 20% glucose over a period of 15 minutes. And a 15 ml preparation of a 20% glucose is now available, which will deliver the required amount after being run through a standard giving site. And if an infusion pump is available, we should use it. But if it wasn't available, then the infusion shouldn't be delayed. And we should repeat the capillary blood glucose measurement after 10 minutes, where if it was still less than 4 millimole, then we should repeat the previous steps. If there was no IV access available, then we should give the patient a 1 milligram of glucagon intramuscularly. And the glucagon can be less effective in patients who are prescribed sulfonylurea therapy and can take up to 15 minutes to start its effect. So the glucagon mobilizes the glycogen from the liver and will be also less effective in patients who are chronically malnourished, including patients who have a prolonged period of starvation or patients with severe liver disease. So in this case, an IV glucose is the preferred option. And once the blood glucose is greater than 4 millimole and the patient has recovered, then we should give them a long-acting carbohydrate of the patient's choice where possible and taking into consideration any specific dietary requirement that the patient might have. So we should note that the patient who are giving glucagon will require a larger portion of a long-acting carbohydrate to replace the glycogen stores, and patients who are self-managing their insulin pump may not need an long-acting carbohydrate in general. Also, we shouldn't omit the insulin injection if the time is due for the injection, but we should review the doses in general. And if the patient was on an IV insulin, then we should continue to check the blood glucose every 15 minutes until the level is above 3.5 millimole. We should then restart the IV insulin after the review of the dose, and we should try to prevent the hypoglycemic reoccurrence. In addition, we should consider a concurrent IV of 10% glucose infusion over an hour for 100 milli. Or we could consider stepping down the insulin increment on the variable scales if it was appropriate. In addition, if the hypoglycemia was due to sulfonylurea or any long-acting insulin therapy, then we should be aware that the risk of hypoglycemia can persist for up to 36 hours following the last dose, especially if there is a concurrent renal impairment. And an important thing to do is documenting the event in the patient note, and we should ensure a regular capillary blood glucose monitoring that is continued for at least 48 hours, and we should ask the patient to continue their treatment or management at home if they are discharged, and also we should give them a hypoglycemia education when indicated. So for adults who are on an MPO condition, if the patient has a variable rate of an intravenous insulin infusion, then we should adjust as per the prescribed regimen and also seek medical advice. So most of the variable rate of the IV insulin infusion should be restored once the blood glucose is above 4 millimole, and even though that the infusion rate adjustment can be indicated. So the option 1 and 2 of the IV glucose are both appropriate treatment option, but also we should follow the local guidelines when they are present. And once the blood glucose is more than 4 millimole, and also the patient has recovered, then we should consider an IV of 10% glucose at a rate of 100 milli for each hour. Also, if the patient is no longer on MBO or has been reviewed by the doctor, then this should be implemented. While if the hypoglycemia was due to sulfonylurea therapy or a long-acting insulin, then we should be aware of the risk of hypoglycemia that can persist for up to 36 hours following the last dose. And also we should document this in the patient notes, and we should ensure a regular monitoring of the blood glucose level and ask the patient to continue their treatment and management at home. In the case of the patient requiring enteral and parenteral feeding, so these patients should be referred to dietitian and nutrition team for diabetes specialized assessment. And the risk factor for hypoglycemia in these cases include a blocked or a displaced feeding tube, a change in the feeding regimen, or enteral feeding that is discontinued, or even TBN or IV glucose is discontinued. Also, in the case of diabetes medication administered at an inappropriate time of the feeding, this can lead to hypoglycemia, and any change in medication that can cause hyperglycemia, such as steroid therapy, will be reduced or even stopped to prevent hypoglycemia. And the feeding intolerance or the presence of vomiting will lead to hypoglycemia and even deterioration in renal function or a severe hepatic dysfunction can cause hypoglycemia. So we shouldn't administer these treatment options via the TBN line in the patient who are receiving TBN, as the treatment should be administered either orally or intravenously as appropriate. We should give the patient, in the case of hypoglycemia, a 20 gram of quick-acting carbohydrate of the patient choice if tolerable or possible, such as a bottle of local juice. And we should give the patient about restarting the feeding rapidly and delivering the grams of carbohydrate. And all treatment options should be followed by about 50 ml of water flushes of the feeding tube to prevent any tube block. Afterward, we should repeat the capillary blood glucose measurement in about 15 minutes later. And if it was less than 4 millimole, then we should repeat step 1, but we shouldn't repeat it for more than 3 treatment options in general. And if the blood glucose level remains less than 4 millimole after these treatment options, then we can consider giving them about 200 milli of 10% glucose administered intravenously. But the care should be taken with the infusion pump setting if any larger volume bags are being used, so that we can ensure that the whole bag is not invertly administered. And once the blood glucose level has corrected and the patient has recovered, we can restart the feeding. And if the patient was using a bolus feeding, we should give them an additional bolus feed, but we should read the nutritional information and calculate the required amount, that is to be given 20 grams of carbohydrate. Also, a 10% IV of glucose that is given at 100 milli per an hour. This volume should be determined by the clinical circumstances of the patient, including if the patient is stable or not, and their hemodynamic stability. Also, we shouldn't omit the insulin injection if the time is due, but we should review the medication. And if the hypoglycemia was due to sulfonylurea therapy or any long-acting insulin therapy, then we should be aware of the risk of reoccurrence of hypoglycemia. And we should, of course, document this in the patient files, and we should monitor the patient every 48 hours for their blood glucose level, and we should ask the patient to continue their treatment at home, and ensuring that the patient is referred for a dietitian for individualized hypoglycemic therapy. So after a successful treatment of hypoglycemia, then we should complete an audit form and send it to the monitoring committee. And also some hospitals have utilized pre-printed stickers in the patient note for the documentation and the audit purposes. And we should also consider completing an incident form if it was appropriate. In addition, we should identify the risk factor or the causes that resulted in hypoglycemia, and we should take measures to avoid hypoglycemia in the future. Also, we should have the inpatient diabetes team to contact and discuss the patient condition in general. And unless the cause is easily identifiable and both the nursing staff and the patient can or are confident that the steps can be taken to avoid any future event, then the review of the medical condition should be discussed. And if a hypoglycemia event was severe or reoccurrent, or the patient voices concerns, then we should have a review of their medication. Also, we shouldn't omit the next insulin injection or start any variable rate intravenous insulin infusion to stabilize the blood glucose. Because if we are unsure of any subsequent diabetes treatment, we should first discuss this with the team, as it can be safe to omit a mealtime bolus dose of a rapid-acting insulin if the patient is declining the food and has taken their usual basal insulin dose. So the medical team is to consider reducing the dose of insulin before the team is previously hypoglycemic event is developed, as this can be helpful in preventing any further future hypoglycemic episode. and we shouldn't treat the isolated spike of hyperglycemia with a stat doses of rapid-acting insulin. Instead, we should maintain a regular capillary blood glucose monitoring, and we should adjust the normal insulin regimen only if a particular pattern emerges. So an important thing to consider is preeclampsia in pregnancy with an induced hypertension as a side effect of diabetes. Sorry. So the preeclampsia is defined as the association of a pregnancy-induced hypertension and a proteinuria of about 300 milligrams for each 24 hours or even more after 20 weeks of gestation. So it is more common in the primary gravidia and in patients with multiple gestation and those having type 1 diabetes or a family history of diabetes. So preeclampsia affects about 8% of the pregnancy and is a severe complication which can even lead to fatal morbidity and mortality. So the risk for the baby include poor growth and prematurity, as preeclampsia can lead to problems in the liver, kidney, brain, and even the clotting system. Also, the maternal morbidity include placental abruption, the HELLP syndrome, which include hemolysis, elevated liver enzymes, and low platelet level, or even eclampsia. And the treatment consists of ending the pregnancy in the severe cases. So early sonogram is recommended, but many women will have to have a total bed rest to avoid the development of this condition. Also, severe preeclampsia that developed at 34 weeks of gestation is associated with a high prenatal mortality and morbidity. So women who are 37 weeks pregnant are induced and to avoid the risk of developing the preeclampsia. The criteria for a mild preeclampsia include hypertension as defined by 140/90, and the presence of proteinuria, mild edema with weight gain, and the urine output that is more than 500 milli. So the signs and symptoms include increased blood pressure, proteinuria, headache, facial edema, rectal pitting edema, and irritability with epigastric pain or oliguria. While in the case of severe eclampsia, the blood pressure will be higher than 160/110, and the systolic pressure rises to more than 60, and the diastolic more than 30 over the baseline, with the presence of proteinuria and massive edema with oliguria. Also, the presence of pulmonary edema, severe headache, and visual changes with right upper quadrant pain and elevated liver enzyme is present. And in the cases of eclampsia, seizures can occur, and the eclamptic seizures and symptoms of the HELLP syndrome can also develop, while in the severe cases, there may be also a hepatic rupture, pulmonary edema, or even acute renal failure. In these cases, the maternal mortality rate is as high as 36%. So because the plasma homocysteine is often increased, a sufficient intake of folic acid, vitamin B12, and B6 is recommended. And studies have shown that the effectiveness of the magnesium in the eclampsia and preeclampsia is helpful and therefore should be supplemented. In terms of the intervention, we should aim to reduce the maternal and the neonatal mortality and morbidity. So in pregnant patients with diabetes and a chronic hypertension, the blood pressure target goal is between 110 to 130 and over 65 to 80 mm. So we should avoid a lower blood pressure because the fetal growth can be impaired at such conditions. In addition, we should reduce the edema when it is present, and we should correct any underlying malnutrition or micronutrient deficiency. And we should monitor for any sudden weight gain, such as 1 kilogram per week, that are unexplained by the food intake. And if possible, we should prevent the development of a chronic hypertension and metabolic syndrome after the delivery. For medication, the only intervention that is shown to prevent preeclampsia are the antiplatelet agents, primarily the low-dose aspirin, and calcium supplementation with magnesium sulfate for the eclamptic seizures. We should also avoid the excessive magnesium from supplement if this medication is being used. In addition, corticosteroid for any lung maturity may be necessary, and during pregnancy, typical diuretic and cardiac drugs are not used, while ACE inhibitors and ARBs are contraindicated in this condition, and calcium pump inhibitors are often the first line of choice as a treatment. For using herbs, it is not recommended for use in pregnancy as it can have some negative side effects. While using the evening promazole has been suggested for this condition, and using CoQ10 coenzyme and the alpha-tocopherol are considered a potent antioxidant and could have some potential effect. For the nutrition education, we should advise the patient on resting, which is essential during this time, and a biofeedback such as meditation, yoga, and other forms of stress reduction are often beneficial. We should also advise the patient on avoiding meal skipping at all costs. We should also discuss adequate sources of calcium from the diet, especially if the dairy products are not being tolerated or preferred, and good sources of potassium and magnesium, including nuts, fruits, and vegetables, are recommended. Also, following DASH diet is an excellent choice even after pregnancy. In terms of food-borne illnesses, if the patient was using tube feeding, then we should educate them on the proper hygiene processes or sanitations. So some of the potential complications for diabetes, as we have discussed hypoglycemia, now we will be discussing the side effect of hyperglycemia. These symptoms include polyphagia, polydipsia, and polyuria, with dehydration and weight loss, and weakness in addition to muscle wasting and recurrent or even persistent infection. So the blood glucose level of 200 milligram or more should be evaluated, and we should monitor the blood or the urine ketones to check for diabetic ketoacidosis. There are three forms of hyperglycemia that may be noted in the hospitalized patient: as someone with a history of a diagnosed diabetes or a previously unrecognized diabetes, and the presence of a hospital-related fasting blood glucose more than 126 milli. Also, DKA or a non-ketotic hyperosmolar state is considered as a metabolic complication due to stress of the illness, trauma, or even aggravated glycemic control can be precipitated. And vomiting illnesses that are accompanied by ketosis can indicate DKA, which is a life-threatening condition that requires immediate medical care to prevent the complication and death. And cerebral edema can occur in these cases with early consultation, and the endocrinologist that is needed can help in preventing these conditions from developing. While the symptoms of hypoglycemia include shakiness, confusion, diarrhea, and irritability with hunger and weakness. Also, numbness of the mouth and the tongue with convulsions and dizziness can be indicated signs, and pallor or slowed speech and tingling with nausea and nightmare also. So when the blood glucose level is 70 milligram, then we should start the treatment with 15 grams of liquid or fat-free glucose source or carbohydrate source. So adding protein to the carbohydrate dose doesn't have an effect on the glycemic response and doesn't prevent any subsequent hypoglycemia, but adding fat can also be retracted as the prolonged the acute glycemic response. So in rare severe hypoglycemic attack, adding the emergency glucagon kit can be used for uplifting the blood glucose values. A common phenomenon with diabetes is the Down phenomenon, which is the end result of a combination of the natural body changes which occur during the sleep cycle. This happens between 3 a.m. and 8 a.m. when the body naturally starts to increase the amount of counter-regulatory hormone, including cortisol, which all work against the insulin action to drop the blood sugar level. So all of these actions can cause the blood sugar level to rise in the morning. While the Sanusi effect, for example, is a rebound hyperglycemia that leads to high blood sugar levels in the morning that precede an episode of asymptomatic hypoglycemia. So when the blood sugar drops too low in the middle of the night, then the body counteracts this mechanism by releasing hormone that rises the blood sugar level. And too much insulin earlier or not enough at bedtime snack can cause or lead to this condition. In the cases of an acute illness or infection, so any condition that will lead to deterioration in the glycemic control will necessitate more frequent monitoring of the blood glucose and also the urine or the blood ketone levels. So aggressive glycemic management with insulin is needed in the case of severe illnesses. As the risk of DKA is higher during this time, we should therefore test the blood glucose and advise the patient to drink enough fluid and ingest carbohydrate every 3 hours if their blood glucose levels are low. Also, a marked hyperglycemia would require a temporary adjustment of the treatment program, and if it was accompanied by ketosis, then frequent interaction with diabetes care team is required. And hospitalization can be needed in these cases while in the pediatric cases, a cerebral edema can develop. Therefore, these should be monitored carefully and, if needed, referred to pediatric endocrinologist. In terms of using vaccines, an annually provided influenza vaccine to all diabetic patients after 6 months of age is recommended as to be provided at least one lifetime as a pneumococcal vaccine for adults who have diabetes. And persons who have diabetes tend to be at a higher risk than the normal for bacterial form of pneumonia. Therefore, this vaccine is recommended. Also, in the critically ill patient, the blood glucose level should be kept as close to 110 as possible, with using intravenous insulin, which is usually needed. Also, we should schedule the parenteral insulin dose that should be given in relation to meals and should be adjusted according to the point of care for the glucose level. The potential intermediate complications of diabetes in children include affecting their growth and development, which may be impaired with diabetes by supplying the patient with adequate protein and energy. Also, their blood glucose level goals somehow is less restricted. And the target range for the near normal glucose should be recommended depending on the patient age, but this can be altered according to their healthcare plan. And the near normalization of the blood glucose level is seldom attainable in children and adolescents after their diagnosis. And their A1C level goals can vary, but most children will have a hypoglycemic unawareness, therefore they should be monitored carefully. In addition, children with diabetes will differ from adults in many ways, including their insulin sensitivity, related to the sexual maturity, their physical growth, and ability to provide self-care. Also, we should work with the family closely and school to monitor the patient's glucose levels. Where for children with type 2 diabetes, for example, it can be difficult to distinguish between type 1 and 2 due to the ketosis that can be present at both types. As children also with type 2 usually are overweight or obese and can present with glycosuria and even without ketonuria. So up to 33% of the ketonuria at the diagnosis can have some ketoacidosis without any associated stress or illness or any infections. While in the pre-consumption state, we should always monitor the female blood glucose control to ensure a healthier outcome of their pregnancy. And in the pregnant women, we should have as much as of a normal glucose control to ensure they have a sufficient baby growth and development. Also, using specialized laboratory at the diagnostic test can be needed, and also women with diabetes must be trained in self-monitoring their blood glucose level. And the nutrition recommendation for women who have a pre-existing diabetes must be based on a thorough assessment. We should also advise them on monitoring the blood glucose level, the blood or even the urine ketones level with their appetite and also weight gain that is needed to develop an individualized nutrition prescription and also to make adjustment to the meal plan. And the plasma glucose should be maintained at 65 to even 100 milligram per deciliter before the meals. And in the fasting state, it should be between 110 to 135 1 hours after the meals and up to 122 hours after the meals. So, as mentioned previously, we should increase the caloric content for the pregnant diabetic women up to 300 kilocalorie on a daily basis to ensure they have sufficient intake. Also, in older adults who have an unexplained weight loss, they should be viewed as a symptoms of developing a problem, as diabetes is considered an important health condition for the aging population. So the new onset diabetes in adults who are over 50 can signal an underlying pancreatic disease that should be investigated. And a strict diet control is not recommended in the long-term care plan, as they would have somewhat less flexibility in their control. We should also modify the medication rather than the diet itself as needed depending on the patient's condition. And we should have a lower hypertension levels that is reduced gradually by following the DASH diet whenever this is deemed possible. Also, supplementing their diet with multivitamin and minerals can be beneficial for this population in specific. So some of the chronic complications for diabetes are retinopathy and can affect approximately up to 24,000 cases of patients with diabetes. So in the presence of a retinopathy or a severe diabetic retinopathy, then we should advise the patient to avoid vigorous aerobic resistant exercise, and where in pregnant women with type 1, this can be an indicative factor for developing retinopathy. In addition, microalbuminuria can be a sign for developing nephropathy, including hyperfiltration and renal hypertrophy, and also the presence or the losses of about 30 to even 300 grams of creatinine in the urine. So the protein losses at a rate of 300 milligrams of creatinine can be indicated sign of advancement toward chronic kidney disease and should be managed vigorously to avoid this development. So to reduce the risk or even slow the progression of nephropathy, we should optimize their glucose and the blood pressure control. Also, nephropathy is preceded by microalbuminuria for several years, and as the onset of end-stage renal disease is about 5 years after the onset or the development of microalbuminuria. And in the case of diabetic nephropathy, we should liberalize their carbohydrate intake and control their insulin levels accordingly. In addition, controlling the protein intake will slow down the progression toward nephropathy, and adults can need between 0.8 to 1 gram of protein per kg on a daily basis, with the protein restriction is of benefit in slowing down the progression of albuminuria, and the glomerular filtration rate declines, and also the development of end-stage renal disease. In addition, protein restriction should be considered in patients whose nephropathy seems to be progressing despite the optimal glucose and blood pressure control, and also the use of angiotensin converting enzymes and the inhibitors or the angiotensin receptors blocker. So an intensive diabetes management with the goal of achieving a near normal glycemia has been shown to delay the onset of microalbuminuria. And we should refer the patient to physician that is experienced in the care of diabetic renal disease when the estimated GFR has fallen below 60. Or if it was difficult to occur for the management of hypertension or even hyperkalemia. Also, ACE inhibitors are almost always prescribed to decrease the progression of albuminuria. Also, if this developed to end-stage renal disease, they will need approximate protein restriction to control the creatinine and the glomerular filtration rate, which should be assessed annually in these patients. Also, for the autonomic neuropathy, about 70% of patients who have diabetes will have a degree of a nephropathy. These include impaired sensation with decreased cardiac responsiveness to exercise, which can lead to postural hypertension, impaired thermoregulation, in addition to impaired skin blood flow and sweating, and impaired night vision with impaired thirst sensation and a risk of dehydration with the development of gastroparesis and unpredictable food delivery. So the neuropathy can be delayed with careful blood glucose management and monitoring from the time of the diagnosis. In addition, weight loss can be beneficial for obese patients to have a better glucose control and therefore preventing such complication from development. Also, diabetes management can affect the skin and the joint with decreased pain sensation in the extremity, which can be an increasing risk factor for skin breakdown or even infection with joint destruction, as it can be best to encourage the non-weight-bearing activities such as swimming, which can reduce the pressure of the joints or even have a better muscle mass in those patients. Also, the genitourinary as the diabetic autonomic neuropathy is associated with recurrent tract disturbance or even bladder disturbance or dysfunction. It should be managed accordingly. And as it is known that lower extremity amputation is very common in patients with poor blood glycemic control and therefore should be carefully monitored and managed in patients with diabetes. For the cardiac involvement, a major clinical manifestation of cardiac neuropathy in diabetes can include resting tachycardia, exercise intolerance, and even orthostatic hypotension, with the risk of constipation or even gastroparesis with pseudomotor dysfunction and an impaired neurovascular function and hypoglycemic autonomic failure. Therefore, we should evaluate the patient for their cardiac status before starting any exercise program to prevent any side effects or negative conditions. Also, the gastrointestinal neuropathy, which is GI disturbance in the esophageal enteropathy or gastroparesis with constipation or diarrhea and even fecal inconsistencies, are common effects and can affect any section of the GIT depending on the condition of the patient. Also, the gastroparesis should be suspected in individuals who have erratic glucose control. So diabetes can have many tremendous effects on the patient's condition, not just a poor blood glucose control, but will lead to the more chronic complication as we have discussed, or even intermediate simple complication that will affect the patient's life in general and daily lifestyle, all of which can be avoided and prevented incomplete if the patient had better blood glucose control from the time of the diagnosis, which is achieved by a simple insulin regimen in type 1 and with a diet plan, or even with dietary intervention in type 2 diabetes or in GDM, and can prevent all future complications if this was followed accordingly. We have reached the end of our webinar. We thank you for your participation. And if you have any questions, please do send them on the chat so we can answer them. العفو، بالتوفيق أجمعين، الله يعافيكم. العفو، بالتوفيق جميعا، وإن شاء الله راح نرسل لكم المادة العلمية. المادة العلمية، المحاضرات إن شاء الله راح يتم إرسالها لكم.